So thank you everyone for joining us for day 2 of the 46th Indian Cooperative Oncology Network Conference. It gives me great pleasure to introduce our organizing secretary, Dr. Lalit Mohan Sharma, who will give the opening statements. Over to you, sir.
Yeah, very good evening, friends. And I'm happy to share with you all that we had a wonderful meeting yesterday. We all wished that we were doing this meeting in physical form, but on digital platform also we had close to 150 participants, and the interest was active till 9:30 in the evening, and we were some 68 or 70 when we ended the meeting. So thank you so much for all the faculty, for all the participants. And today we will be having a power-packed academic session. And to start the first session, may I invite my dear friend Dr. Asim Samar. Dr. Asim.
So
Yes.
Dr. Asim is stuck in another meeting, so we'll move on to our chairpersons. It gives me great pleasure to introduce our two chairpersons, Dr. K. Pavitran, Professor of Medical Oncology at Amrita Institute of Medical Sciences, Kochi, and our second chairperson, Dr. D.C. Dole, who's the Chairman of Medical Oncology and Chief of Breast and Thoracic Services at Rajiv Gandhi Cancer Institute, New Delhi. So may I request Pavitran sir to please introduce our first speaker and also to give the introduction comments.
Yeah, so today we'll start with the breast cancer session. And for the first talk, I invite Dr.
Sophia, please share the screen for Dr. Reshma Puranik.
Dr. Reshma Puranik for the talk on choosing the right PARP inhibitors. Please from Pune. Dr. Reshma, please.
Yes, very good evening, sir. I would like to share my screen.
Sure, ma'am, please go ahead.
Is it visible?
Yes, ma'am, your screen is visible.
Okay. A very good evening to all the respected faculty, and thank you so much, Dr. Malhotra sir, Dr. Sharma sir, for inviting me today for this talk. And without delaying much, I would like to start the topic. So choosing the right PARP inhibitors. So we have a lot of PARP inhibitors now that are coming up, and apparently for the outset they do look the same, but there are very, very important differences that we need to know before we choose the right PARP inhibitor. So the PARP inhibitors, like this is a breast session, that I would like to discuss the role, like how do we choose the right PARP inhibitor in ovary cancer and breast cancer. So whenever PARP inhibitors are discussed, I'm sure ovary cannot be left out. And if time permits, I will touch upon a little on pancreas and prostate cancer. So mainly focusing on, first of all, how do we choose these PARP inhibitors based on the indication, and then based on the toxicity profile, and how do they differ from each other, and what are the various indications. So proceeding further, the 5 PARP inhibitors that right of now we are aware are olaparib, rucaparib, niraparib, talazoparib, and veliparib. I'm sure all of us must have already used olaparib and rucaparib, and we are very well averse with their safety profile and handling and tolerability. And the other 3 are also in the pipeline, and we are sure we'll start using them also. So they are all overlapping, but they are not 100% concomitant. And they also have overlapping toxicities, but they do have some unique toxicities that are unique to each one of them. So that is where we need to know the difference and how do we choose the right PARP inhibitor. So first, I'll be discussing the importance of PARP inhibitors as far as ovary cancer is concerned. So the 3 different PARP inhibitors that have been approved by US FDA with their own specific indications and individual toxicity profiles. So we have olaparib, niraparib, and rucaparib. So the first indication, olaparib, is first-line maintenance therapy for Braca mutated advanced ovarian cancer, which is having a response to platinum chemotherapy, as well as a maintenance in approval along with bevacizumab, who had response to platinum-based therapy. So this is the first-line maintenance approval, which also niraparib is having, but niraparib is having the first-line maintenance approval regardless of the Braca mutation status. So this is where these two differ, and rucaparib as of now is not approved. Veliparib, we are having data which is coming up, so that will also may come in the indication soon. Now coming to the second indication is common to all 3 of them. So as far as recurrent ovarian cancer patients are concerned, then is an approval irrespective of the Braca mutation status we can use in patients of recurrent ovarian cancer in those whom are platinum sensitive. All 3 of these drugs, olaparib, niraparib, and rucaparib, are approved. And coming to the last indication, so this is an indication where the patient can be platinum resistant also. We have already used 3-4 lines of therapy. We are not now exhausted, and the patient also So as the patient progresses, we see their PS going down, they're having comorbidity, they're not really very fit for IV chemotherapy agents. So this is when, even if the patient is having platinum resistant, but if the patient is BRCA mutated, if it is germline, we can use olaparib. If it is germline or somatic, we can use rucaparib. And even if the patient is homologous recombinant deficient, we can use niraparib. So these are the indications of PARP inhibitors as far as ovary cancer is concerned. Now, coming to the basic pharmacokinetic differences in these three drugs, we can see niraparib is the one which is having a very good bioavailability, and it is also having a longer half-life. So it is having an once-a-day dosing, whereas the other two are having twice-a-day dosing. Metabolism, olaparib and rucaparib metabolized in the liver. Now coming to the PARP inhibitors dosing. So the olaparib is dosed as 300 milligram twice a day. We have dose reductions of 50 milligram available. Then niraparib is dosed once a day, dose reduction to 200 or 100 as per toxicities. And the rucaparib is dosed as 600 milligram twice daily. So this is as per the bioavailability difference and the bioavailability, which is, and the half-life, which is determining the dosing. And the trials I'll be touching upon in short a very few significant points that these trials offer. Before we go to the trials, we have the dosage form, the tablet formulations which are available that we are all aware of. And now the hematological toxicities. So hematological toxicities are common to all three of these drugs. But as far as niraparib is concerned, the toxicities are much more. So the niraparib, they have advised that we should monitor the CPC much more frequently as compared to olaparib and rucaparib. Then this is the, even though the toxicities are common, rucaparib is the one in which the hematological toxicities are almost in 50 to 60% patients. So it is requiring dose modification more frequently. Olaparib patient, if the patient having renal dysfunction, then the patient requires dose modification at the outset, or if he develops renal dysfunction later on, we'll be requiring a dose modification. And as far as rucaparib is concerned, the hepatotoxicity incidence is a little more with this medicine. So dose modification with niraparib is required. Even with niraparib, if the patient has outset a hepatic dysfunction, a dose modification will be required. Now, these are very common points that we see practically in a clinical practice. And so when we try to choose the PARP inhibitor, we should consider all these 3 points. And like I told you, the monitoring for niraparib is much more frequent as far as the CBC monitoring is concerned. Now, if a patient has a blood pressure issue, if a patient is having uncontrolled hypertension, niraparib is not a very good drug to use, because many patients have landed up with hypertensive crisis if they are having uncontrolled hypertension. Then coming to olaparib, the unique side effect for olaparib, besides the commoner ones, pneumonitis and venous thromboembolic events. And as far as rucaparib is concerned, I think hepatotoxicity is a little concerning. So all 3 of them, hematological toxicities, GI toxicities are common, but renal dysfunction, we may want to avoid olaparib, and in a patient with accelerated hypertension or uncontrolled hypertension, we may want to avoid niraparib. So these are just the few highlights which I wanted to point out in this slide. Now, just touching a little upon the, in very short, the important trials which led to the approvals. In maintenance, first line, it was the Solo 1 and the Paula 1 trial for olaparib, which showed a very, very good PFS benefit, which was 56 versus 22 months, and the Prima trial for niraparib. So these are the trials which led to approval of these PARP inhibitors in the first line maintenance setting. And as far as the recurrent ovarian setting was concerned, we have the Ariel 3 trial, we have the Nova trial, and the Solo 3 trial, which was in the recurrent platinum sensitive setting. So in the recurrent setting in which the patient is platinum sensitive, irrespective of the BRCA status, we can use all of these 3 molecules. So we can choose any of these 3, but it is important to see your patient, not only the patient, the side effect profile, but we also need to see the cost, the availability, and many other factors before we decide on which PARP inhibitor exactly to choose. And in the 4th line setting, where the patient is platinum resistant and 3-4 lines have already been used, and if the patient is germline BRCA, we can use either olaparib or niraparib and niraparib. And as far as rucaparib is concerned, even a homologous recombinant deficiency can be an indication to use this medicine in the recurrent setting. And if the PFS benefit, if we were to actually see the efficacy wise, we saw the different side effects, we saw the different indications, but if we were to see the efficacy, then it is, if you see the PFS benefit is a little higher side as far as olaparib is concerned. It is a slightly different domain, but overall the PFS benefit is overall the same, slightly more in the olaparib arm. So coming to the approvals beside ovary cancer, Olaparib in ovary cancer, we saw it is in the first line maintenance, second line maintenance, as well as recurrent setting. It is also approved in breast cancer, metastatic setting, as well as adjuvant setting, and in prostate and pancreas cancer in the metastatic setting where the patient is BRCA mutated. So Olaparib has a wide range of approvals. As far as Niraparib is concerned, as of now, we are having approval in the first line maintenance and in recurrent ovary. In the other, the trials are going on, but approvals are not yet, they are not yet in the NCCN guidelines. And if Rucaparib is taken, Rucaparib has been approved in the recurrent ovarian setting. As of now, Rucaparib does not have an approval in the first line ovary maintenance setting, but it is approved in prostate as well as in pancreas. I have done a cross, but it is approved in pancreas also. And in the breast, Rucaparib is as of now not having an approval, whereas Talazoparib, based on the Brca trial, is having an approval in the metastatic breast cancer setting. This table, I feel, is very important. We should know the exact indication where these PARP inhibitors are approved, so we choose the right drug in the right indication. And there were few studies in which they compared the efficacy and tolerability. These few tables which is down is also important, because if we see the PARP inhibitors, as far as the toxicities, treatment interruption and dose reductions were concerned, Olaparib was 25% versus 68 versus 54, treatment interruption 45% versus 66 versus 63, and the adverse events 36 versus 74 versus 54. So Olaparib overall had a little less adverse events, less dose reduction, and less treatment discontinuation as far as the other two molecules were concerned. This has also been pointed out in the above graph. So Olaparib overall has a better tolerability as far as these data is concerned. So there was one more US study in which they saw what was the proportion of patients persistent and adherent to index PARP inhibitor. So where they saw persistent was the percentage of patients with no index PARP inhibitor regimen treatment gaps of more than 90 days. And adherence was measured as a ratio of sum of days supplied during the fixed 6-month follow-up period, and patients with an MPR less than 80%. So if we can see in these graphs below, we can see the adherence as well as the persistence.
Ma'am, 1 minute left, ma'am.
In the Olaparib arm. So the grade 3 interruption, dose interruptions, as well as the adherence was the highest with the Olaparib. So it is important to recognize these different adverse events as far as these three molecules are concerned. And if we see just one point, anemia was highest in the Rucaparib and in the Olaparib, whereas hepatic dysfunction was more in the Rucaparib. So this is some important things which I want to point out as far as toxicity is concerned. So these are the indications of PARP inhibitors that we just saw. Approved indications for Lynparza. Since the time is limited, I'm not able to go into much details of this. The few NCCN guidelines photos in which I can show you that Olaparib has been approved in the metastatic setting breast cancer, and also in the adjuvant setting, Olaparib and germline BRCA mutated in the adjuvant setting. So there are specific indications in this, which is highlighted in this table below in NCCN, that we need to see before we use the adjuvant Olaparib. In prostate cancer, again, Olaparib and Rucaparib approved for germline BRCA positive patients in the metastatic setting. Also in pancreas, Rucaparib and Olaparib have now been approved for those patients with germline BRCA positive. So the take-home message for this presentation today, Olaparib has a wide range of approvals across all the 4 different tumor types. I have highlighted its exact approval: first-line maintenance, second-line maintenance, recurrent ovary setting. But like I told you, we have to, before we choose Olaparib, there are few things that we need to keep in mind. Rucaparib has been approved in ovary, prostate, and pancreas. Niraparib has been approved in ovary, and Talazoparib has been approved in breast cancer. So these are the specific indications. There are a few specific different toxicity profiles of these 4 drugs. As far as the overall adherence is considered, persistence, and the overall tolerability, Olaparib has fared much better than the other 2 drugs. And not all PARP inhibitors are same. The approvals indications vary. The pharmacokinetics, dosing is different, and individual PARP inhibitors have a different unique toxicities, and that require attention and customization. So to end this topic, not all PARP inhibitors are same. We have to see their indications and the exact toxicity profile, availability, cost, and everything before we decide upon the right PARP inhibitor. And more approvals and indications coming up for these molecules. Thank you so much for giving me an opportunity to talk. And I was a little fast, but the data is so much to cover, so I had to be a little fast in my talk. Thank you so much.
Thank you, Dr.
Thank you so much, ma'am.
Excellent presentation. Yeah. Now we'll go for the panel discussion. Is PARP inhibitors in BRCA mutated advanced breast cancer. By then the moderator is Dr. Prasad Narayanan from Sidecare Hospital, Bangalore. Over to Dr. Prasad, please.
Good evening. I thank the organizers for the opportunity. So the Panelists for today's discussion: Dr. Bhavesh Parikh, Dr. Akshay, Dr. Ankit Agarwal, Dr. Aditi Mitra, and Dr. Tarachand Gupta. Dr. Chetan was there in the list before, but he has sent his apologies. Are the other panelists there? Because I cannot see.
Yes, sir. All 5 panelists are there.
Okay, fine, thanks.
सर प्रसाद बोल रहा हो तो कोई नहीं आ सकता है, हो सकता है सर.
Sir, good evening, sir.
Good evening.
So this is the topic given was that PARP inhibitors in BRCA mutant metastatic breast cancer improve survival, or does it improve survival? So we will try to take it through the panel and see in next 20 minutes whether it improves survival or not, in what setting. So we know that approximately 5% of the patients will have a BRCA mutation in unselected breast cancer population. And this is when you take the patients who have a family history with breast or ovarian cancer, we just heard from the previous speaker also, it almost becomes 24%, which is even more in an Indian data which was published. So more than a quarter of the patients will have BRCA mutation. And specifically, if you look at TNBC patients and the hormone receptor positive patients, TNBC patients have got a higher percentage of BRCA mutation. So with
Dr. Prasad,
yes.
You are not on that slideshow mode and slides are not moving probably. Can you do it on slideshow?
It is in slideshow for me, but
Kashish, can you help him?
Sir, can you reshare your screen again, sir?
I will do it again. 1 second.
Have you made it full screen?
Is it?
It's not full screen at our end, sir.
Huh?
It's not full screen at our end.
Okay. So can somebody help me with this? You don't have the slides, is it? I have sent an email.
Sir,
I think.
Sir, can you reshare the slides? Because I don't think we have your slides, sir.
It is okay. We will do it without that actually.
Okay.
Sure, sir.
It is mostly about discussion. So we have, can the panelists see the slides? Are they okay with the
So
slides?
it's the first slide. Currently,
No,
it's only the first slide.
Now?
Sir, it's still the first slide. Sir, I request you to please mail it. We'll share the screen from our channel.
No, it's mailed already, Kashish. It is mailed 2 days back. It's not moving, is it?
Means Prasad, if you are moving, but we have only that first slide, that's your presentation. You now just move to the second slide. Yes, it's now moving. No problem.
I think without this, okay.
Because it was not full, it was some problem.
This way it is okay.
Yes. Yeah, Prasad, it's okay.
We'll go. Sorry for this technology issue. So this is a 58-year-old lady with a triple negative breast cancer, clinical CT3N1M0 disease, treated with the 4AC, 12 cycles Paclitaxel and Carbo, and at surgery the patient had a pathological CR and received radiation, standard treatment. Baseline BRCA was not done, and in 6 months' time, second follow-up visit was done. And like many patients who have TNBC, the patient had a metastatic disease, and this was liver, bone, lung, and lung metastasis. So I will start with Dr. Bhavesh, sir. Sir, what percent of your patients you do baseline BRCA mutation in metastatic breast cancer? This is a 58-year-old lady without family history.
10%.
10%. Can I run this through the other panelists, Dr. Akshay?
Yeah, hello.
Yes.
I'm audible?
Yes, you are.
Yeah, actually, we see the patient profile and will tell for the Braca testing. As far as consider 60 years, below 60 years TNBC, I advise every patient to go for Braca testing. But out of 10 patients, 4 patients might get tested
so
for the
in your
in TNBC.
25%, not 40%.
25%. Yeah.
And Dr. Ankit, what is your take in a percentage about what percent of your patients will go for a BRCA testing at baseline? Dr. Ankit, Dr. Aditi Mittal.
So hardly 10% of the patients undergo Braca testing.
Okay. Dr. Aditi?
Yes, so finance is a big problem, I think. So 5 to 10%, that's the maximum that we get.
And Dr. Tarachand Gupta?
The same as.
Right. So on a roughly, I think from what the panelists say, maybe doing a baseline BRCA testing in metastatic breast cancer, unless there is a very strong family history, is not very common in our practice. So this patient also did not get. Now the question is again that when this patient comes back after 6 months for the follow-up visit, and you have given your most active treatments, AC and paclitaxel with carboplatin in this case, do you go for a BRCA testing at this point of time? Does the percentage increase? We'll run it again through the panelists. So, Dr. Bhavesh?
Absolutely, sir. This is the time generally we are doing BRCA testing, and generally we are trying to do germline and somatic both. But sir, again, the most important question, as you rightly asked also in the initial, sir, in 58-year-old lady, TNBC, no family history, whether on the baseline also we should ask or we should not ask?
Right, right. I think that is the point of discussion. So, Dr. Akshay,
I feel, yes. I feel even if at a presentation, if the criteria as we have discussed, less than 60-year TNBC, a germline BRCA is must. Whether we are use it for later, like suppose patient gets metastatic and we have a report with us whether germline BRCA is present or not. And at the onset of metastatic, that when the metastasis happens, at that time we should send for BRCA. That is for sure.
Right.
In this TNBC.
Dr. Ankit and Dr. Aditi and then Dr. Tarachand, can you also say whether you will test for BRCA in this patient when there is a metastasis? Will the percentage increase?
Yes, sir. Of course, we will ask the patient to get the test, and yes, the percentage increases, and we also insist on getting the patient to get the test done.
Sure. Dr. Tarachand?
Yes, sir. I think the TNBC patient, in my opinion, should undergo for the genetic screening at least.
So I think we heard the panelists. So definitely BRCA testing, when we have the primary treatment exhausted, we are doing it more frequently, maybe more than double of the as baseline. So the reason for that is some data which we have about PARP inhibitor therapy, and that is why we are having this panel discussion. So I will take you through some of the data on PARP inhibitors, first as monotherapy. And this is the latest ESMO guideline, which actually says, if you see that in metastatic TNBC patients, germline BRCA, then chemotherapy based with the platinum or PARP inhibitor based therapy is given as one of the first line options here. And the basis of that are some trials, the monotherapy trial, the Olympiad trial, olaparib monotherapy versus physician's choice chemotherapy. And this is in patients like our patient who had an anthracycline and taxane, failed, and less than or equal to 2 chemotherapy lines in metastatic patients. This patient qualifies for this trial. So 300 milligram per twice a day of olaparib versus physician's choice. This patient, if we give chemotherapy, obviously the choice would be either capecitabine, eribulin, or vinorelbine, or maybe gemcitabine. So what did the Olympiad trial show us? This was the data. If you take the primary endpoint of PFS, there was a 42% reduction in the risk of progression from 4.2 months, which is very dismal. There is a progression-free survival improvement to 7 months, which is significant from a PFS point of view. And if you see the overall survival, the curves are very close to each other. There is a numerical improvement, but it is not statistically significant. That is what the take from the Olympiad trial is. Similarly, there is a trial with talazoparib, the Brca trial. Again, phase 3 trial, 145 sites, 16 countries. Talazoparib versus physician's choice, similar indication, less than or equal to 3 previous lines of chemotherapy, and almost similar outcome actually. I would say that the PFS again in the chemotherapy arm was 5.6 versus 8.6 for the talazoparib arm, and overall survival was not statistically significantly improved. So there are trials with the not yet approved data from niraparib as well as for rucaparib. So these are the monotherapy trials, And I will ask specifically the two of my panelists for their take on these trials and as their comments on PARP inhibitor monotherapy. So Dr. Bhavesh, you please tell me about your opinion, and you should be focusing as PARP inhibitor as the choice of therapy in this, and then followed by Dr. Tarachand, who can speak against it.
Prasad, as you rightly mentioned and shown various trials, with the PFS advantage, definitely, and the even p-value is significant, I will definitely go for monotherapy, and that is olaparib. There may be a different PARP inhibitor also available and depend on the patient's toxicity profile or patient tolerance or patient comorbid illness, even the prior taxanes and anthracycline, what is the duration between the metastasis and adjuvant treatment, the other parameters like age, young patient, family history. So at present, looking to all the data and various for various PARP inhibitor, I will in this particular patient will go for olaparib, that is monotherapy. I had a choice about the especially eribulin, but definitely I will go for olaparib in this particular patient.
Sure, sir. Dr. Tarachand, your take on this? Can I get Dr. Tarachand?
Yes, boss.
Yeah.
I think, Dr. Prasad, this is not fair. You have started my battle against like Ukraine versus Russia, and again I am against.
You have NATO support, yeah. You can go ahead, yeah.
And without NATO support, right? You are not giving the platinum in the platinum sensitive disease, and we are giving us such a toxic molecule also that have suggested that around 5 to 6% discontinuation because of the anemia only. And patients are having significant nausea and vomiting, and the most worrisome is the also the fatigue, which is usually we underscore during our practice, because sometimes patient says, "Oh, I am feeling just weakness," but we just ignore that it is weakness. You are not eating properly, or you are not doing something. And this molecule, if we see these both the trials like Brca and the Olympiad have not shown any OS benefit till now, the updated analysis, and with the PFS benefit is very marginal. And usually in breast cancer, when we are talking about breast cancer metastatic, the survivals are very good. Even in third line, we are having very good combination drugs. And if the patient is platinum sensitive, or we combine with the platinum, especially triple negative breast cancer, those should respond very well. And I think it is not in my opinion, it is not a fair trial that it should be against the combination.
Right. So we heard the pros and cons of PARP inhibitor monotherapy here. We'll come to a conclusion slide in the end. Let us see whether PARP inhibitor in chemotherapy in metastatic breast cancer, what does the trial results say? So this is the Brocade trial, the phase 3 trial of veliparib with carboplatin and paclitaxel, double-blind placebo-controlled trial with a primary endpoint of PFS. If you see the outcome, the combination had a PFS of 14.5 versus 12.6, and the median overall survival 33.5 versus 28.2. And serious adverse events in the combination is not as very significantly different. So again, a PFS improvement, which looks significant and promising. Almost 14% extra patients should survive if you give a combination of chemotherapy with the PARP inhibitor in this group of patients. What are the other combinations which are under test? Again, all the usual, all the PARP inhibitors, there is data with in combination, some of the ongoing studies as well. So regarding this question, if Dr. Akshay, you can take up this question and say that in this patient who seems to be a fast recurrent patient, you would add a chemotherapy combination with PARP inhibitor. And Dr. Aditi, you can say your comments against it.
See, as far as this data is considered of Brocade 3,
right.
It is what I just reminded what we are doing for lung cancer, like adding gefitinib, osimertinib along with the chemotherapy. So one is targeted and one is the disease is taken care by chemotherapy. Though there is no data for olaparib as such, there is no mature data, But the Brocade data is it looks promising. Whether adding Paclitaxel along with Veliparib, it will improving the PFS. But still, we have to wait for the OS analysis. Right. Second thing, as far as we don't have only Veliparib available here, so we might think using Olaparib along with Platin or Eribulin to see the toxicity, we can do this way. And we can continue Olaparib afterwards if the patient is clinically having some symptomatic metastasis, like if this patient is having bone metastasis, lung metastasis, and even liver metastasis. Giving only PARP won't be sufficient for this patient. So at the backbone of chemotherapy, yes, patient can be improved faster, and patient the response rate also I can expect to be more than only single agent PARP or single agent chemo.
Sure. Dr. Aditi, your comments against it?
Sir, of course, the two main important things is the adverse events, which was worrisome in this trial, which was seizure. I would also, of course, look for that. And also, the overall survival data is not yet mature. Right. And till the time, I would like to go with the chemotherapy rather than adding a drug, which of course added to the toxicity, both financial and physical. And of course, fatigue, as that Dr. Narayanan mentioned, that fatigue is a very important adverse effect, which we tend to oversee in our patients. So noted. Still there is time. Yeah.
Sorry. Any other point?
That's it, sir.
Yeah. Okay. So again, the thing comes about the lack of overall survival benefit and adding a toxicity. That's your point. Taken, well taken. So let us see whether we can avoid chemotherapy and give a combination with the immunotherapy, because immunotherapy in triple negative breast cancer is coming up in a big way. So there are trials which have looked at this endpoint. Niraparib with pembrolizumab, almost 21%, 49% disease control rate, median PFS 2.3, single arm study. Definitely it will be single arm now. We don't have a randomized study in this setting, but heavily pretreated patients, some positive data of combining PARP inhibitor with immunotherapy. Patient has already failed anthracycline, taxane, and platinum in this case. Similar data with olaparib and durvalumab. Again, the disease control rate was 80% at 12 weeks, which is pretty 50% at 12 weeks, 28 weeks, I'm sorry. This is again impressive data in BRCA mutated, heavily pretreated patients. Other combinations, yes, there is a trial. There are trials which are looking at different immunotherapy drugs with PARP inhibitors. So this is the last discussion point. And since Dr. Chetan is not there, I would request Dr. Bhavesh sir to take up. What is your take on? Do you think that we will have a combination of PARP inhibitor plus immunotherapy in this group of patients, sir?
I am very clear at present that there was still some time to wait for immunotherapy plus PARP inhibitor. Definitely in the future time, we can have a promising data. But at present, I will not go for PARP inhibitor plus immunotherapy.
So there is nobody to speak for this combination. Dr. Ankit, what are your comments against it? And you can also say some points for.
Bhavesh sir has made my job very easy, sir. No, I think so. It's very immature as of now, and we have a very good data of immunotherapy. Obviously, we don't know the data in BRCA mutated patients, but as of now, it's very immature to use PARP inhibitors with immunotherapy. I think a better trial and a randomized trial will help us a lot in deciding where does immunotherapy and PARP inhibitor combination stand as of now in these patients.
So thank you. So I think we covered the data, monotherapy, chemo combination, and immunotherapy. We will look at the Cochrane review, which I also was reading for the first time about this specific question. What is the impact of PARP inhibitors in locally advanced or metastatic breast cancer? Small advantage in overall survival with hazard ratio of 0.81, but definite improvement in PFS, either alone or in combination. This is the 5 trials which I put on the phase 3 trials. The hazard ratio for PFS is 0.63. So definitely something to look into, and overall survival data, as all the panelists said, is not mature. And the overall survival curves, the forest plot is almost touching the center, and definite improvement in the PFS, which we see. So I would say that in summary, what the PARP inhibitors are a welcome addition to the treatment, definitely in metastatic germline mutated, BRCA mutated patients. There is definite evidence, no doubt about that, as monotherapy or in combination in PFS. Overall survival isn't statistically significant, but numerically favorable. So worth question, and maybe further trials when we have data, I think we will have answer to this question. So if any other panelist has any comments on this, we will take it, or any questions from the chat.
Prasad, the first most important point, 58-year-old, no family history, TNBC,
Right.
Baseline or on the metastasis. I will do on metastasis.
Okay. Okay.
Dr. Prasad.
Yes.
While selecting a PARP inhibitor in a first time, like after adjuvant or patient has treated with adjuvant and this is first recurrence.
Right.
So will everyone consider the what is the clinical status of the patient? If patient is like having dyspnea, bony pains or enzymes altered, their chemotherapy stands quite clearly against the only oral PARP inhibitor, I feel. And then we can switch over to PARP inhibitor once the disease burden gets decreased. What is your take on this? Like,
so that depends upon the, I mean, it's a balance which we have to strike, right? The disease response also is important. So it will be something where we have to see whether a combination in some form can get both in control, and then we can go for a targeted therapy. Actually, we all want biomarker based therapies, right? That is in such a tough patient who has relapsed after 6 months, any biomarker based therapy.
Yeah, I have one patient who progressed on PARP. Now this is PARP was used as a 4th line treatment, and now I've started her on eribulin. So let's see how she responding. 2 cycles are over.
So I think that's all I have from the panel. If there is any back to the organizers, thanks for the opportunity. Thanks to all the panelists.
Thank you so much.
Thank you so much, Prasad sir, and thank you to all the panelists. I now request Dowell sir to please introduce our moderator and take the next session forward.
The next session is the panel discussion on HR positive or negative metastatic breast cancer treatment in a 65-year-old lady with diabetes mellitus since 20 years and HbA1c of 7.6, and this will be moderated by Dr. Seema Gulia from Tata Memorial Hospital. Dr. Seema, please.
Thank you so much, sir. And it gives me great pleasure to also introduce the panelists. Dr. Stalin Chaudhary Bala, Associate Professor, Department of Medical Oncology, Nizam's Institute of Medical Sciences, Hyderabad. Dr. Neha Chaudhary, Consultant, Department of Breast Oncosurgery, Narayana Super Speciality Hospital, Howrah, and also at Rabindranath Tagore Institute of Cardiac Sciences, Kolkata. Dr. Vivek Agarwal, Director and Senior Consultant, Department of Medical Oncology and Hemato-Oncology at Narayana Super Speciality Hospital, Kolkata. Dr. Rohit Swami, Consultant, Medical Oncologist at Narayana Multi Speciality Hospital, Jaipur. Dr. Mangesh Kamath, Senior Consultant and Medical Oncologist at Helios Cancer and Hematology Clinic at Bangalore. And Dr. Rajiv Kasliwal, Diabetologist and Endocrinologist at Mahatma Gandhi Hospital, Jaipur. So unfortunately, our moderator is facing some issues. So if we have any questions for our previous two panels, if Prasad sir is here, and if anyone has any queries, we would request them to please, you can ask them you can raise your hand and we'll unmute you, and you can ask your question to the experts. So can I request our Towel sir to please give your comments for the last two sessions, if possible, sir?
The last session, that was a discussion on PARP inhibitors in breast cancer, and this is an area where multiple PARP inhibitors are available, and a few of them are being used in CA breast. And I think we had discussion on those particular points, and I think there now, with the availability of drugs in India, PARP inhibitors are being used in BRCA1, BRCA2 patients with CA breast. About the second thing, I think we should be very careful regarding the management of the patients with comorbid conditions like diabetes mellitus, which is long-term, complication and not well maintained. So I think those, if possible, this panel discussion should be held if we are ready.
Sure, sir. Thank you so much, sir. And I now request Seema ma'am to please start her moderation. Over to you, ma'am.
Hello, good afternoon. Thank you so much for the invitation. And without further delay, I'll just share my screen. Is my screen visible?
Yes, ma'am, it's visible.
So we are going to discuss a case of metastatic breast cancer, which is hormone receptor positive and HER2 negative. And we have the panelists with us, Dr. Satlin Bala, Dr. Rajiv Kasliwal, Dr. Neha Chaudhary, Dr. Vivek Agarwala, Dr. Rohit Swami, and Dr. Mangesh Kamath. So begin with the case. We have a 65-year-old postmenopausal lady who has diabetes since last 20 years, which is fairly well controlled, and her HbA1c is 7.6. She is diagnosed as a de novo metastatic breast cancer, and on biopsy, it revealed an ER7+, PR6+, and a HER2 negative. This is the staging workup, which shows that there are a few liver mets, there are lung mets, as well as there are, you can see that there are bone marrow mets, and there are at least 3 to 4 sites of bone marrow metastasis. The hemogram is within normal limits, though hemoglobin as well as the platelet count is on the lower side, and her liver function as well as hepatic function is within normal limits. So I would like to ask the panelists, what would be their choice of therapy? This patient is not in visceral crisis by definition, but she has significant amount of disease burden. So what would be the choice of therapy? So I'll begin with Dr. Vivek.
Yeah, thank you, ma'am. Ma'am, the patient is now having borderline cytopenias with ANC of 1200 and with bone marrow metastasis. It will be probably ideal to do a bone marrow aspiration biopsy.
This is PET scan show there is bone marrow involvement. Yeah. So there is no
and if I remember correctly, bone marrow metastasis with cytopenia is a visceral crisis. So nowadays there is a good debate whether even in visceral crisis you can use CDK4/6 inhibitors in hormonal therapy or not. We all know that even if you use chemotherapy or you use CDK4/6 inhibitor, there is going to be a significant cytopenia. So one way of starting treatment may be starting some low dose chemotherapy, maybe a weekly paclitaxel, so as to control the disease, and then later on shifting to a hormonal therapy with CDK4/6 inhibitor. I would probably do that because the patient has bone marrow metastasis and there is cytopenia. And if somebody wants to start hormonal therapy with CDK4/6 inhibitor, that is also correct. But I would be really concerned about cytopenias because the patient already has borderline cytopenia now.
Okay, Dr. Rohit, what is your opinion? Hello, Dr. Rohit, are you there?
Ma'am, Dr. Rohit is not there, ma'am.
Okay, Dr. Rajiv.
Ma'am, Dr. Rajiv is also not there.
Okay, Dr. Mangesh.
for the question, madam. I would agree with Dr. Vivek. So the depth of cytopenia is also very important. So if the patient is otherwise not symptomatic due to the neutropenia, then I probably might even, and otherwise the patient is fine. I would not be averse to using letrozole and CDK4/6 inhibitor as well with some GCSF given to just kind of make sure. But before that, definitely bone marrow aspiration biopsy would be very important for me to do. If the patient, even if I feel that I'm not comfortable with CDK4/6 inhibitor and otherwise the patient is fine, then I don't mind even going for letrozole alone and till I get the bone marrow aspiration biopsy report. I am not so concerned about neutropenia with the CDK4/6 inhibitors until unless the depth, I mean, we have what we call as deep grade 4 neutropenia. We have seen a lot of that happening even when we start patients on therapy. So I am still okay starting with CDK4/6, but if the patient is highly symptomatic, then paclitaxel is a good choice.
Any patient is not much symptomatic with the disease.
Yeah, just want to add one thing. Want to add more, ma'am. That if somebody wants to start CDK4/6 inhibitor, I think Abemaciclib is the drug to go to rather than Ribo or Palbo because of the bone marrow disease.
Yeah, agreed. Dr. Setlin, what would be your choice?
So I agree with the last comment, madam. So but definitely I will be going with letrozole with CDK4/6 inhibitor rather than chemotherapy in this patient because she is not that symptomatic and the myelosuppression is not that much. The platelets are more than 1 lakh, ANC is more than 1,000 and the hemoglobin is more than 10. So definitely my choice is giving a AA plus a CDK4, preferably abemaciclib because that doesn't cause much myelosuppression.
A little comment on the choice of CDK4/6 inhibitor. I totally agree with Dr. Vivek, who said that Abema will be the lesser of the evils. But at the same time, we know that sometimes these neutropenic patients, they can get diarrhea. So with Abema, if in case there is a diarrhea, then we might be in trouble because we don't know what is the diarrhea due to. That is one challenge. I have particularly treated a case like this, at least 3 cases, not 1, but 3 cases, where I did find that it was okay to use ribociclib in those patients. It did work well, and little bit of enzyme derangement on the liver was not an issue for me in those cases.
Yeah, so completely agree with all the panelists. So it's basically the choice of CDK4/6 inhibitor. You can debate based on the predominant side effects that we see with these CDK4/6 inhibitor, but either a chemotherapy or a hormone therapy with CDK4/6 inhibitor is a reasonable choice. So ultimately, this patient, we started her on weekly paclitaxel, to which she had a very good response, and then she was continued on the letrozole as a maintenance therapy. But within 3 months, she progressed. There was increase in liver as well as lung metastasis, and there were new onset bone lesions. At the baseline, there were only bone marrow mets, but at progression, she had bone metastasis as well. So how would you like to manage this patient now? So let's begin with Dr. Mangesh this time.
Yeah, so progressive disease, how is the cytopenia, madam? Sorry, I don't know if the cytopenia improved or not. That was also
cytopenia,
very important.
Yeah, cytopenia improved, and at this time point also there is no significant cytopenias.
And how symptomatic is the patient, madam? Is it just a radiological progression, or is it symptomatic progression as well?
There is increase in lung as well as liver metastasis, but she is not majorly symptomatic with that.
Okay, and was the bone marrow? Sorry to ask this question as well. Was the bone marrow involved when we started the patient on Pacli?
So, as per the PET review, the bone marrow was involved. We did not do a bone marrow aspiration and biopsy.
Awesome. Okay, so my choice this time definitely would be to go for letrozole with letrozole with CDK4/6 inhibitor, and if not letrozole, I would also prefer fulvestrant because this patient is diabetic. So I would probably look at fulvestrant also, which is not a bad choice according to me.
The patient progressed on letrozole because after paclitaxel, she was on letrozole as a maintenance therapy.
All right, so fulvestrant with the CDK4/6 would be my choice.
Okay, Dr. Vivek, would you like?
Ma'am, I totally agree. Kind of depends upon how soon after letrozole the patient progress, because if it is less than 6 months, then kind of indicates primary hormonal resistance. But again, when we have CDK4/6 inhibitors not being used, then definitely both are an option. We can go for a chemotherapy or we can go for CDK4/6 inhibitors. And if the progression post letrozole is more than 6 months, I would be more confident on starting hormonal therapy plus
So the
CDK4/6.
patient progresses within 3 months. So she is hormone resistant by definition.
Yeah, so this is kind of a primary hormonal resistance. But again, only hormonal therapy is not adequate. We need to add something to to mitigate this resistance. And I think CDK4/6 inhibitor plus fulvestrant is a good enough choice for the patient.
Okay. Dr. Bala, what would you do?
So I agree with both the panelists, madam. So my option would be fulvestrant plus a CDK4/6 inhibitor.
Okay. Anybody would like to do something else? Do you want to repeat biopsy and look for any specific mutation and then take a call what should be done?
I was going to say the same thing, madam, that we probably also have to do a repeater biopsy to try and see if the receptor status is concordant to the baseline, or we probably and another thing is, even if it turns out to be just ER/PR and HER2 negative, I would still want to do if there is an ESR ESR1 mutation and all those other profiles that we are so interested in. So I would definitely want to do all this.
Yeah. So PIK3CA mutation is also something that we need to check.
Yeah. So I agree with that. Yeah. So out of ESR1 and PIK3CA, which mutation would be helpful in deciding the treatment at present?
I would go with PIK3CA inhibitor. PIK3CA mutation testing.
Yeah, because so this patient underwent repeat biopsy. It was ER positive and PR negative and HER2 negative, and PIK3 mutation was positive. So given the fact that the patient has a PIK3CA mutation, now what would be your choice? Would you give CDK4/6 inhibitor with fulvestrant, or would you give fulvestrant with alpelisib? Dr. Bala, let's begin with you this time. So which therapy would you choose out of these two and why?
So post progression with a single agent hormonal therapy, the much data is with a single agent hormonal therapy, the much data is for a fulvestrant with CDK4/6 inhibitor. So preferably I will be going with fulvestrant plus CDK4/6 inhibitor. If at all she progresses, I may be continuing the fulvestrant, changing it to alpelisib.
Okay, Dr. Vivek, what would you do?
Well, ma'am, what data that we have is that patients who have PIK3CA mutation positive, they don't do as well with CDK4/6 inhibitors as those who are negative, but still CDK4/6 inhibitor does remain a choice. Most of the data with alpelisib is usually a post CDK4/6 inhibitor, but we do have a good segment of patients who are naive to CDK4/6 inhibitor. It is difficult to say what should be the ideal sequence, but if the patient can afford and if it is feasible, I think alpelisib plus fulvestrant is something that I can go, and then I can give a tamoxifen with the CDK4/6 inhibitor later on, or exemestane plus CDK4/6 inhibitor later on. So okay, probably I'll go with alpelisib with fulvestrant because patient is PIK3CA mutation positive. If you look at the PFS, in second or third line, I think the alpelisib data has a better PFS as compared to CDK4/6 with fulvestrant in PIK3CA mutant positive population.
So 2 points here. I mean, in the SOLAR-1 trial, only 7% of the patient had received prior CDK4/6 inhibitor. So it is basically the reverse case. Most of the patient are CDK4/6 inhibitor naive when they were treated with alpelisib in the SOLAR-1 trial, right? And we should not compare the trials because there is no head-to-head comparison between PI3K inhibitor and a CDK4/6 inhibitor. But given the fact, if we look at the PFS benefit, obviously it is more with the CDK4/6 inhibitor compared to PI3K inhibitor. Dr. Bala, would you like to differ, or you will agree with Dr. Vivek?
So most of the times I will be using fulvestrant with CDK4/6 inhibitor because there is a robust data for CDK4/6 inhibitor in the second line, even with the patient who is having a prime endocrine resistance. So my choice would be possibly a fulvestrant with CDK4/6 inhibitor in this line, madam. In the later lines, I can be using alpelisib.
So this is the initial data of PFS regarding with the use of alpelisib, and we have seen there is a PFS benefit which was statistically significant. But this is the updated OS data, and which, though it is numerically better, but it was not statistically significant. So in light of this data that there is only PFS benefit but no OS benefit with the use of PI3K inhibitor, Dr. Vivek, would you still want to go ahead with alpelisib? Or would you prefer CDK4/6?
Well, ma'am, I think, PFS benefit and the OS benefit, the debate still goes on, and we all need to remember, even in the Palbociclib data also, we never had OS benefit but PFS benefit only. There is crossover in all these studies, and PFS benefit, whether it is good enough to give in second or third line is still a vital question. But my point is that if we look at the benefit from CDK4/6 inhibitor in the PI3K mutant cohort in the patients, then you see that the PFS benefit is somewhere near, the PFS is somewhere near 6 months, 7 months. It is not as high as 16 months what we see in the patients who are not PI3K positive. So if we know that the patient is PIK3CA positive, then I think alpelisib will give you a better PFS, although it is a difficult drug to handle. Diabetes is, again, a patient is already a diabetic, so there are difficulties, and either of the choices, we don't have any head-to-head study, it is difficult to decide like that. But if we know that the patient is PIK3CA positive, then probably we need to give this targeted treatment now and look at the other targets later on.
Okay, so what do you think will be the most challenging side effects that is seen with these PI3K inhibitors and which are difficult to manage?
Yes, ma'am. Diabetes, of course, once you start, it is very common to see patients having sugars of 500, 600. So that we have to be very, very careful. And then skin rashes, and then skin itching is another one. Diarrhea is another one. So these are the toxic, nausea, fatigue, all these are the major problems. But diabetes is a major challenge, and it is actually difficult, because you very frequently see two of my 3 patients will present with a blood sugar of 300, 400, 500, like that. That is what is happening.
So it is indeed a difficult drug to handle. So Dr. Kamath, what is your take on the side effects with the PI3K inhibitors?
Madam, the side effects of the PI3K inhibitors remind me basically of the combination of exemestane with the everolimus. They are like very similar. It is not an easy drug to manage. That is why I would still prefer, irrespective of the fact that my benefit will be lower, I would still go to CDK4/6, especially ribociclib in this situation with fulvestrant. Now, having you asked me the question of managing alpelisib, yes, I think we are still learning about how well to use alpelisib. Should we go on the full dose or not? And I believe that we are not yet ready to go for the full dose. See, numerically managing the diabetes is one thing, but at the same time, there is also other host of symptoms that we are struggling with. So I personally I believe that we should not start with the full dose of alpelisib initially. Try to go a little more considerate and a little more conservative in our dosage initially, and then probably escalate as time goes on. I mean, we had the same challenges, and there are still so many consultants who profess the use of everolimus despite the side effects, and alpelisib is no less evil compared to everolimus in that sense. So I think we basically have to start on a slightly lower dose, and then as tolerated go and escalate.
Yeah, even if we look at the SOLAR-1 data, there were 74% of the patient who had dose interruption, and dose reduction was done in close to 64% of the patient.
Ma'am,
So
2 minutes left, ma'am.
Yeah, so 300 milligram probably is not the dose which our patient will tolerate. So if you have to choose between alpelisib and everolimus, both will target the PI3K mTOR pathway. We have a predictive marker for alpelisib, but no predictive marker for everolimus. So it will, in overall population, it has shown PFS benefits. So which one will you choose? Dr. Bala?
Definitely, I will choose the alpelisib, madam, because everolimus, the major side effect is the mucositis I have observed in my patients, so which impairs the quality of life, their feeding. So that will ultimately lead to the loss of weight for these patients. So comparing both drugs, definitely I will be choosing alpelisib over everolimus.
Okay, so we have surgeon also with us, Dr. Neha. So Neha, when would you consider surgery in these metastatic patients?
So, ma'am, in this particular case, I think the only role of surgery is if either the local disease is such, which is fungating, bleeding, which we cannot manage otherwise, or if there is some other event, maybe a skeletal event, which needs fixation or fracture. Otherwise, I can't see a role of surgery at present in this case.
Yeah. So this is the BILIV study, and Vivek, this is particularly in patients who were prior exposed to CDK4/6 inhibitor, and it was seen that this alpelisib is still effective in patient who has been exposed to CDK4/6 inhibitor. There is also a study which was published in Annals of Oncology, and they basically, the investigator looked at the time course and how do we manage the side effects. And this is very interesting to know that patients who were being started prophylactically on antihistaminics, there were significant risk of toxicity as well as dose reduction. And similarly, if proactively the blood sugars were monitored and managed, the incidence of grade 3 for toxicity was also reduced for hyperglycemia as well as for the diarrhea.
Ma'am, apologies, we're running short of time.
I'm just concluding this. I came across this very interesting case report that there was a case report where tumor lysis syndrome has also been noticed with the use of alpelisib. So to conclude, the therapeutic landscape of metastatic hormone receptor positive breast cancer is continuously evolving. There have been many attempts to target this PI3K mTOR pathway, but still we have not seen OS benefit with the use of newer drugs with this in the metastatic breast cancer patient. Education of the patient, prophylactic use of antihistaminics, as well as careful monitoring and early intervention is very crucial if we plan to use PI3K inhibitor in our patient, and we have to be very cautious in the elderly patient. I would like to thank all the panelists for this wonderful discussion which we had. Over to you.
Thank you so much, ma'am, and thank you to all the panelists. We'll now move on to our next session. I now request Dowell sir to please introduce our next speaker.
Yeah, I'll invite now Dr. Biswajit Dubashi, who will be talking on a very important topic of Trastuzumab Deruxtecan in treatment of HER2 low metastatic breast cancer. Dr. Biswajit, please.
Thank you, Dowell sir. I would like to thank the organizers for giving this opportunity. I'll just quickly share my screen. Good evening, everyone. The topic given is quite an interesting one. How useful is Trastuzumab Deruxtecan in treating HER2 low metastatic breast cancer? So I think what I'll be discussing in the next 10 minutes would be the definition of a low HER2 new breast cancer. Is this going to be a new entity? Will anti-HER2 new agents have similar efficacy in this subset? Evidence of use of anti-HER2 agents in this setting. What are the roles of this antibody drug conjugates, especially Trastuzumab Deruxtecan in this setting? So there is a lot of debate on whether HER2 new agents will work in patients who have a low expression of HER2. And so over the period of time now, they have devised the algorithm to define what would these patients be. So if any of these patients have an IHC 2+, which is weak to moderate complete membrane staining in more than 10% of the tumor cells, and or FISH negative, or incomplete membrane staining, again more than 10%, those two will be as IHC 1+, will be considered as low HER2 positive breast cancer. And if you do not have any staining, obviously they'll be HER2 negative. So what are the implications in terms of numbers? You can see HER2 positive breast cancer, the frequency is somewhere between 15 to 20%. And HER2 negative, which is actually no stain, is around 30 to 40. So there seems to be a big chunk of tumor, which seems to be representing this HER2 low breast cancer. Now the question is whether they are pathologically pathogenesis and everything is different in this subset. Yeah, there is a lot of data now coming up that these HER2 low breast cancers completely behave differently from this HER2 negative breast cancer. So there has been a renewed interest after the drug conjugates have come in, whether we could target this population, which is the HER2 low breast cancer. So over a period of time, a lot of novel agents have been described and tried in this HER2 low expressing breast cancers. Basically, they're divided into 4 groups. It could be monoclonal antibodies, antibody drug conjugates, bispecific antibodies, and vaccines. So age-old monoclonal antibodies like trastuzumab, pertuzumab have been tried, but not very successful. The antibody drug conjugates, yes, very promising. But the classical antibody drug conjugate, which is the TDM1, probably is not working. The Trastuzumab Deruxtecan seems to be promising, and the newer ones also seem to be promising. What about bispecific antibodies? Again, there is some phase 1, phase 2 data, but again, don't seem to be very promising. And the vaccines, again, not currently seem to be promising. So the next few slides, I'll try to show you some of this data which is available. We can see the initial when studies were done with trastuzumab. It's very clear that there seems to be no advantage of using only trastuzumab in this IHC 1+ or 2+ tumors. The second trial was basically they looked at 2 different doses of pertuzumab and checked whether if you use a higher dose of pertuzumab, you could get responses in this particular subgroup. They actually did not find the difference in terms of responses when you use the higher dose. So, but this exactly again says that probably pertuzumab also does not work. So the classical HER2 agents probably do not work. Then came data on conjugates, and then you have the drug called trastuzumab emtansine, and that is our TDM1. And very clearly, this was not again a randomized study. It was a phase 2 single-arm study where they had patients with HER2 positive breast cancer and compared with the HER2 low breast cancers. And obviously, the responses were very, very low with HER2 low breast cancers. Then came the phase 1 data on trastuzumab deruxtecan. Though again, this was not a randomized data, but this was an initial phase 1 dose expansion study. And they looked at an overall response of 37%, looked very promising, but we required more evidence before we say that it probably works in the low HER2 breast cancers. Now, what about the this we have already discussed. This is the deruxtecan data. Now the there was another antibody conjugate. Again, there seems to be some improvement in the overall response. Again, they are just single arm studies and very difficult to comment on them. Then we have the vaccine trials. The vaccine trials, again, not very promising. The control vaccine group as well as the control group, the DFS were almost similar. So currently we don't have any data on the vaccines. Sorry, the bispecific antibody data, again, as I said, that the response rate seems to be not there, though the disease control rate is 53%, but that doesn't seem to be response rate. So again, probably the bispecific antibodies are not working great. Now, if you look at the various drug conjugates, the TDM1, the SYD 986 and the deruxtecan, there seems to be a difference in the way they are, the property, the chemical property is there, and also the way the cytotoxic moiety gets dissipated. So if you see the TDM1,
and the next you carry on with the
So the TDM1 clearly says that they do not have a bystander killing effect. The diffusible cytotoxic moiety is not available, whereas the bystander killing effect is much more in the SID986. But you see that Trastuzumab Deruxtecan, there seems to be a much more advantage in terms of diffuse cytotoxic moiety. And the more important is that they have a very high payload, drug load, where we could actually have 8 drug loads to 1 antibody, which seems to be more effective in this subset. So you can actually clearly see that this is the TDM1, which actually cannot be cleavable. So it cannot cleave and it has to enter in, which makes it more difficult, and it cannot diffuse between the cells. Whereas you can see that Deruxtecan can actually enter, cleave, so it can just break open this. And so patients which do not have an antigen on them can also get affected by this payload, and they can also get diffused across the cells. So there seems to be more bystander effect on this. And you can see the payloads are also very high in numbers when compared to the TDM1. So there seems to be a lot of things happening with Trastuzumab Deruxtecan with combination with the immunotherapy, especially in the HER2 low breast cancer. A lot of phase 1 and phase 2 study happening. The toxicity, interesting slide, that the toxicity is, again, we know that the conjugated drug toxicity are completely different. They could have an on-target, off-target side effects. But with respect to Trastuzumab Deruxtecan, there seems to be this interstitial lung disease, which seems to be a new issue with this subset of drugs. So again, we can see the interstitial lung disease seems to be high, almost like 13% grade 1, grade 2, grade 3 disease. So this, again, we have already discussed that this drug seems to be different in terms of other antibody conjugate because it has a lot of drug into it. The linker can be cleavable, and it has the potency to cross the membrane. So this one is the phase 1b study, specifically looking at the HER2 low breast cancer in 54 patients. Look at the number of cancer regimes they have used before. It's almost 45 patients, 83% received more than 5 prior cancer therapy. And they had a response rates of almost 70 to 80% of these patients had a response. So it seems to be working in this subset of patients. Very early data on the PFS, but there seems to be some data that it is working. I know that Breast03 study is not basically on the low HER2 new, but I think this is a data which is completely turning the way we are looking at this particular drug. This drug, the number of patients with HER2 3+ were maximum, but only 10% of these patients only had low HER2. But the magnitude of benefit which this drug has on HER2 enrich seems to be very high, p-value which is actually not seen ever in any of the trials we have ever seen with 10 to the minus 22. So the Destiny Breast04 is the study which we are all clearly waiting that the results of this would help us, because this is a data which is only in the HER2 low breast cancer. So 4 days back, they have declared some of the results. I'm not able to actually find the exact data, but it says that there are statistically significant improvement in the PFS and OS when compared to the physician's choice chemotherapy. So the take-home message from the from all this is that significant proportions of HER2 new breast cancer have low expression. Looks like a new entity for which therapy would be developed in the near future. The traditional anti-HER2, the Trastuzumab, Pertuzumab, seems to be very ineffective in this subset. The drug conjugates are very promising. The reason for that being the bystander effect. The Trastuzumab Deruxtecan of all seems to be more unique because it has both the cleavable linker, diffusible cytotoxic moiety, and the property of more drug getting attached to the antibody. The Destiny Breast03 study seems to be a study which has a remarkable PFS in the HER2 enrich, again giving a suggestion that this drug is more effective than the traditional anti-HER2 data. And Breast04 results seems to be promising. They have not declared the numbers. I was not able to find anything because for 5 days AstraZeneca just declared the results. So thank you once again for giving this opportunity.
Thank you so much, sir. I now request our session director, Dr. Asim Samar, to please introduce our moderator and our panelists. Asim sir, are you there? So can I invite Pavitran sir to please introduce our moderator?
Next session is by Dr. Sahoo. The panel discussion on dual blockade in HER2, hormone receptor positive and HER2 positive metastatic breast cancer. Over to Dr. Sahoo, please.
Thank you, sir. We have all the panelists now?
Yes, sir. All the panelists are there.
Yeah. So thank you, and thank you, organizers, on behalf of myself and the panel, which will be having a very short answers because we have a 20 minutes panel discussion, and we start at 6:20, so 6:40 is where we hand back to the organizers. Okay, I'll just share my screen. I'll just see if it goes full screen. Okay, I'll go again. Okay, so we had this, and let's go to the case. And I think my slides are visible and I'm audible.
Yes, sir.
Yeah. So we have a 57-year-old female, postmenopausal, diagnosed with cancer breast, and the patient received adjuvant chemotherapy with 6 cycles of 6 months of trastuzumab, and then radiotherapy. The patient is ER/PR positive and HER2 positive. So the patient was on tamoxifen 14 months and now has been diagnosed post 14 months on hormone therapy with 2 liver deposits, multiple pleural and bony metastasis. So patient is not in a visceral crisis. So I want to make it very, very clear on that. So approach very quickly in one-liner, Dr. Mehboob sir, do this patient for you is eligible for a repeat biopsy?
Yes.
Okay. And in your practice, do you feel that irrespective of the patient facing the going as per the biology, if there is a doable biopsy site, you always would prefer for the new biopsy site?
Always, yeah, always.
Okay. So I think as medical oncologists, we have been evolving in this aspect, at least in lung, in breast. In most of the sites, we try to get a biopsy, although the changes are not much there, but there are changes which are very specific and a lot of the things do matter. So I feel that was one point which I wanted to highlight. Now I come down to the approach. Dr. Vikas, how would you approach this case? With biopsy was done. So first, can you tell me what would be a goal of treatment? Patient is not in visceral crisis. The patient is a ER/PR positive, HER2 positive, metastatic breast cancer, postmenopausal, failed tamoxifen, have had a interval from the tamoxifen use of around 14 months before the patient relapsed. So what would be a goal of treatment? Response, PFS, OS, or quality of life with PFS and OS?
OS with quality of life, sir.
OS with quality of life is what you put through, because what you are telling me, I will ask you when you give me the choices for treatment. So that is why I want to first take the commitments here. Dr. Maniar, would you tell me what would be your treatment? What would be your goal of treatment? Hello? Dr. Shefali, if you're there, can you please quickly tell me this?
Yeah. So I'm there, sir. So, I think if you ask me goal of treatment, all are the goals. If you ask me the preference wise, of course, quality of life with PFS or OS, followed by, OS, PF, and response, then PFS.
Okay.
Yeah.
So basically, all of us, we would be very happy if we get all of them. But what I'm getting from both the panelists, at least the quality of life data with a PFS, and if you can get a OS, very nice. And Vikas is committed to get a OS for us. So let's see what he does for us. Okay. So now, Dr. Arpita, first you and then Dr. Jayesh, and then I'll come to Dr. Mania. Can you tell me what would be your treatment choice? And I'll go to every panel on this, because this is where the whole crux of the discussion will go on. So in this patient, everything has been given to you. Anything more you want, you just can tell me. First, you tell me what, and then we'll come to why. Dr. Arpita.
Sir, I'm a pathologist, so I think I will give away with this question.
Okay, sorry. So I'll come down to a very different question for you. How frequent in your data set have you found the change in the receptor status? And how often do you find your clinicians in your hospital advising a repeat biopsy in such cases?
So it's uncommon for our people to be asking for a repeat biopsy.
Okay.
And I mean, your question is that how frequently the receptor is changing?
Would change. Yeah. Not sure.
So not
Okay,
sure.
that's fine.
Not sure because we have a variety of places getting samples from variety of places. The same patient may not turn up with us, every time.
Okay. Fine. I take your point. Dr. Maniar, can you take this? The frequency, I think all of us know that it's around 5 to 15% is where we are looking at that. So can you tell me the treatment option for you?
So, sir, I'm assuming this is a triple positive on the fresh repeat biopsy.
It is.
And then my first choice would be a dual HER2 with AI if financially it is feasible. Otherwise, AI with trastuzumab is a reasonably good alternative.
So AI with trastuzumab or a dual HER2 blockade with AI. Is that what you are talking? Okay.
Yes.
Dr. Jayesh?
Dear Sahoo, good evening.
Yeah. Sir, option.
Yeah, my option is to refer because I'm a surgical oncologist. So I would refer if he is from Bhopal, I'll be referring TP.
That was the best answer I heard in the panel. But sir, what do you think?
But I know. I can tell you that now.
I'll ask a different question to you. Do you think we medical oncologists are using expensive drugs without any much of benefit?
No, I would not agree with that.
Okay.
I do agree that we need a lot of teaching from the guys like you. Because, we are surgeons. We are not that updated. But yes, in such a panel, I need to read. And I realized that, we should not be thinking that this guy is stage 4 and she is going to die. I think, yes.
Sir.
Now I know.
Sir, I have a question for you. I have a different
Please.
Question for you. I'll come in after some time. Dr. Mehboob, sir, what would be your choice?
So my choice, irrespective, I mean, I'm not looking at money as a,
there's no concern for money in this panel.
The chemotherapy and dual HER2 blockade.
Chemotherapy and dual HER2 blockade is what you're looking at.
And afterwards, after chemotherapy is over, the hormone therapy. That combination you haven't added here.
Yeah. So you are talking of an induction chemotherapy with a dual HER2 blockade and follow it up with a hormone therapy. That's what you mean?
No. Chemotherapy with dual HER2 blockade. Once the chemotherapy is over, dual HER2 blockade plus hormone therapy.
Yeah, that's what I meant. So okay, sir. I totally take your point, sir. Dr. Vikas, your choice. Vikas?
Sorry, I was on mute. My option will also be like AI with trastuzumab. So
AI with trastuzumab. And Dr. Shefali?
So I agree with Mehboob sir. So to start with, dual HER2 blockade chemotherapy after 6 months of therapy, seeing what is the response, I'll put her on maintenance dual HER2 blockade plus AI in case of good response.
So do you feel, if I'm getting from Mehboob sir and you, that you feel that in this subset of patients, the chemotherapy acts better with the HER2 new agents?
Sir, in any of these patients, whether hormone positive or not, and it's a triple positive, we know that driver is HER2 here, and we need the response considering the liver disease, liver mets also. So considering that response in any of the trials, if you see Cleopatra, even if you see pertain to both of places, I mean, induction chemotherapy, what you say was permitted, and we cannot differentiate what was the response. And the forest plot already showed that once there was a heavy visceral burden, I think the graph skewed in favor of dual HER2 blockade plus chemo.
I don't think that will be an appropriate setup for this case. Mehboob sir, Mehboob sir, do you feel that same question? Do you feel that in a HER2 new triple positive, because the HER2 new you feel has to be targeted, chemotherapy is the best companion for the HER2 new?
So you have to go by the evidence best. So evidence,
and what is the evidence for that?
Evidence with chemotherapy is Cleopatra. Evidence with AI is alternative trial, where PFS is only 11.8 months. OS data has not been published. While in Cleopatra, we know that there is an 15.8 months versus 17.4 months, and there is an OS data. So obviously that that there are patients who are going to live longer, at least median of 55 months, 56 months with Cleopatra. She is just 57. So you want her to live longer, obviously. So that would be a better choice.
Okay.
The chemotherapy drug along with that.
So I get both of your points, and I'll come down to see in the panel in the 10 minutes more left. Can we change the viewpoints? Because I feel you have a point of view, and that is there, and there's some evidence to that. Dr. Manya, there is a data which all of the two above panelists are telling that they would go and prefer a chemotherapy as the companion, not a hormone therapy on this. What is your take? Because you chose something very, very different.
Correct, sir. Sir, I have two basic issues. One is, number one, this patient, I believe, has not received optimal adjuvant therapy. The patient has received only 6 months of trastuzumab. Also,
would you say today, if the patient is a low risk disease in the adjuvant, 6 months is not good enough?
I believe, sir. In my practice,
I believe so, because that's for some other panel someday. But I'll remember this when we do some other panel with you. But my point is, okay, carry on. Okay, please carry on. Then
more so, sir, now more so that the patient has now relapsed in a reasonably short period of time. I believe quality of life, yes, is extremely important. I believe this patient is not in visceral crisis. In Pertain 2, which is a phase 2 randomized control trial, I believe chemotherapy was optional. It was not a mandatory setting at all. And the data is enough for us to believe that a dual HER2 blockade with hormone therapy is enough to provide them reasonably decent PFS, except for Cleopatra, which I'm not sure this is the right patient to extrapolate to. I don't see survival benefit in the current patient setting by adding chemotherapy.
Because your viewpoints, and you are on mute. Please unmute.
I believe I have said that I would like to give an AI with trastuzumab for this patient. Not much in visceral crisis right now. Progressed on tamoxifen and trastuzumab. So I would like to give on the basis of, I believe AI with trastuzumab will be my choice for this.
Okay, I will show you a few slide sets and then we'll come back to the panel.
So can I add?
Yeah, please, sir. Please, sir.
Yeah.
Please, sir. Please, sir.
You know, if there are two phase 3 trials, one is Cleopatra, where definitely you have a OS benefit, and you know that 56 months is the median OS over there. There is another one, Danish. It's a real world data. You know, they have used instead of docetaxel, because sometimes people cannot tolerate docetaxel. So Venorelbine, even there also they found that Venorelbine with dual blockade had PFS something around 34 months. And if you see with any of the AI alone without chemotherapy trial, dual blockade, you have not crossed 25 months.
Okay. So I'll come down to a few data sets and then we'll discuss this, because this is the crux of the whole panel actually. All of us agree that the single agent AI in a financially sound patient is not an option. Can I take it as that, Shefali?
No, not exactly. Finances are an issue. So we are talking about if science, so leave apart finances.
That's okay. Science and financially is not a challenge, then single AI is not an option.
Yeah, so my point of insisting chemotherapy and dual HER2 blockades is because of two reasons. Number one, we have seen across many trials that over and above single HER2 blockade dual has a PFS added advantage. And once the patient has a visceral burden of disease, if you see all of these trials where single or dual HER2 blockade along with hormone therapy was tried, they have excluded the patient in whom chemotherapy were intended. In most of the trials, they have written the clear line that patients in whom chemotherapy was intended were excluded. So, I mean, I believe that where there is a visceral disease, so
I'll come to that, because these trials, most of them, if you look at it, actually took around 70% or beyond of these patients had visceral disease in across trials. So I think all of us exclude visceral crisis. That's what the inclusion criteria meant. But all of these trials did have bone and of visceral, and most of them had visceral, not amount crisis. Let's come to alternative, which is the lapatinib, trastuzumab AI versus the other arms were a single agent of the HER2 new and the AI. And this is what it was. If you look at it of the PFS data, it looked little more superior in favor of the dual HER2 new. Apart, and it was better than both the arms, and the responses were something which the dual HER2 new consistently has seen. And if you look at it, it actually the responses doubles or triples. So if you have a bulkier disease, it does make sense to probably to go for a dual HER2 new blockade. If this is not an issue, you do not have a level 1 evidence, no phase 3 trial as such, but this is the data that is best there. Responses are definitely superior. So, Dr. Vikas, now if a patient is not in crisis, has a visceral disease which you want to have a response, and finance is not an issue, would you change to your option of a single agent HER2 new blockade to a dual, probably in this cases, the hormone agent being constant?
I would.
Okay, so now you're shifting probably to a dual HER2 new. Okay, let's go to. And if you look at this data for OS, because that given data was for us, can we change the OS? And if you look, it is just missing significance. It's 0.07 sitting on that, and just the hazards is 0.6, but the confidence interval little wide beyond 1.4. So this is the data. This is the data which I'm very much interested in. This data does look to me, although it's a phase 2 trial, but has some data in it, which in Dr. Sudeep, when he concludes after us, I want him to also comment on this one. And this is what I looked at, and I want Dr. Mehboob also to come in, and Dr. Maniar here. This data is very clear. All of you know what the trial was designed for. I'm just picking up for one thing what that it is. Look at the curves of the event-free probability. When you look at it across the pertuzumab, trastuzumab combination with a hormone versus trastuzumab arm combination, the curves separate and the hazard is 0.65. But look at the lower two curves. If you look at the lower two curves, you look at the right side, those are the patients who received induction chemotherapy for 4 to 6 months and then switched over to the arm. And that left side where the curves are still very, very separated out, did not receive induction chemotherapy. So what I take home, and Dr. Maniar, can I come in here? For it does it not make sense to give induction chemotherapy if you're looking at it, and then probably save this patient from a dual HER2 therapy and give trastuzumab and a hormone therapy here?
So 4 minutes left, sir.
Yeah, we'll finish. Please tell me. Dr. Maniar, what is your take on this point? But this I found was very interesting. Dr. Mehboob, can you come in? Yeah, please. Dr. Maniar, you were saying something. Dr. Mehboob?
No, he's on mute. He's
okay.
Maniar, he's talking.
Maniar, please everyone unmute yourself because we are 5 of us and we can go quickly. Dr. Maniar?
Let me, let me.
Yeah, Mehboob sir, please, one of you, please go.
So I will go with a phase 3 trial when it is available rather than discussing on phase 2. So it would be better for me to discuss with the Cleopatra rather than pertain.
Which the Cleopatra was the inclusion criteria only meant for this endpoint and this patient subgroup.
So in Cleopatra already somewhere around 46% of the patients were included like what your patient is there. So she has already received the treatment.
Okay.
So that will be a perfect group rather than this one.
Okay. I concede that much.
Sir,
but
can I
please.
Have a word? So, if we are talking about the endpoints, and endpoint in pertain to was also not to assess whether induction chemotherapy made a difference in
No.
Whether dual HER2 blockade plus AI versus trastuzumab and AI.
I totally meant it, but this is something very interesting, and this I felt was worth a mention because when we individualize patient come with different pockets, and if I have to and cannot afford a dual, I probably will ink towards this. Okay, now this is one trial only that is compared in a randomized way. Mehboob sir, a hormone therapy plus a trastuzumab and a chemotherapy and a trastuzumab. This trial on inflated design proved that this patient, the approach of hormone therapy and the chemotherapy was actually non-inferior, and it just missed the margin of superiority. Just missed the margin of superiority because it was 1 and it was 1.04 or something. So Dr. Shefali and Dr. Mehboob sir, does this only one phase 3 trial which on a 1-to-1 head tells us that hormone plus dual HER2 targeted therapy is good enough? Sir.
I know this is a Chinese which was presented last year in the ASCO, which had shown that
and now sir, this is published. This is published now.
If there is a issue of quality of life, your patient is 57-year-old.
Yeah.
Obviously she should be good health. If suppose somebody is elderly, then I would like to definitely go with the hormone therapy with dual blockade.
Okay, so, point taken. But this is I felt was very, very important. And last point criticism for this was it did include most of the patient who did not have a bulkier or more metastasis. The number of metastases were less than 2 in majority of the patient. And the DFI of less than 24 or more than 24 was the only statistically significant in the forest plot. So probably they meant that if the patient is relapsed within 2 years, the patient would probably benefit more from chemo plus trastuzumab based therapy. So these are variables which I wanted to point out. And the real life data is also there from the National Cancer Database, which showed that hormone plus the trastuzumab are non-inferior to the chemotherapy. So last word, Dr. Vikas, any thoughts of adding CDK4/6 inhibitor to the combination of anti-HER2 and hormone therapy? Vikas, quickly. Shefali, can you take that?
Yeah. So there is data, sir, to add on CDK4/6 inhibitor to trastuzumab and AI. If the patient has received previous 2 or 3 lines of treatment, of course, I would tend to use that if my patient is not a candidate for chemotherapy, has progressed on dual HER2 blockade and AI. So it's a good option. Monarcher, I was mentioning, yeah.
Monarcher actually mainly looked at this part, and it's a very early trial. And if you look at the post-hoc analysis, actually showed that all the arms were similar. Although the primary endpoint was that, I am not going to go into this, just time is out. So I conclude the bulk of the disease and the time interval from the initiation of previous hormone therapy matters, as I showed in the Chinese trial. And second, the combination of agents targeting both pathways is the standard of care. You might take chemotherapy into the option, but the evidence is gradually growing towards this, except for in the very bulky disease. But Dr. Mehboob and Shefali, both of you have a point for that. Evidence proving non-inferior hormone versus chemo with trastuzumab. We have the Chinese trial. Can induction chemotherapy negate the advantage of dual HER2 new blockade? This is, although the data is very early, no take-home conclusion, but this is something very interesting which I felt is worth a mention. And the CDK4/6 inhibitors are making headways still very, very early. And toxicity matters, as Dr. Mehboob told. If it's elderly, your concern of toxicity are probably the hormone plus HER2 new targeted approach is the best way to do that. So I thank you. Thank you, panel. Thank you, organizers. And I would love to listen to the expert here.
Thank you so much, sir.
Sahoo, for the excellent panel discussion. Now we'll move on to the expert comments by Dr. Sudeep Gupta, who is the director of ACTREC Mumbai. Dr. Sudeep, please.
So, good evening, everyone, and I thank the organizers for the opportunity today. The panel discussions were wonderful, including the first one by Dr. Seema Gulia and this one by Dr. Sahoo, as well as the talk by Dr. Biswajit Dubashi. And as always, as I'm growing older, I begin to learn more and more rather than be able to make comments in this situation. I think the data that was presented by Dr. Sahoo was really interesting, the Chinese trial, as well as the real world data. And essentially it suggests that at least in some patients in whom the disease has an indolent behavior, it may be okay to use endocrine therapy with HER2 targeted therapy rather than jump onto chemotherapy in every single patient. And I think in the absence of robust multiple phase 3 trials, there will always be a difference of opinion on this, and there is no one correct answer to the question. I think the natural history of any single patient's disease, as well as the disease burden and the velocity of the increase of the disease, also needs to be taken into account while determining the treatment, as well as, of course, the wishes of the patient. So I congratulate everyone. I just want to make one more point that I think the drug antibody conjugates, antibody drug conjugates have come of age. And unfortunately, most of our patients who are unable to access those treatments at present. But I hope that that will not remain the case in the near future. And except for TDM1, which I believe is still accessible to at least a substantial minority of our patients, the other drugs will also soon become accessible, because this is one class of drugs that I believe is really making a difference, at least in the metastatic setting. So with those comments, I will close, and I believe the organizers are already about 9 minutes over time. So I will hand it back to them. Thank you very much.
Thank you so much, sir. And thank you to everyone in the session. We'll move on to our next session. This session is sponsored by Pfizer. The topic is matching real-world data with clinical trial data in HR positive, HER2 negative, metastatic breast cancer with Palbociclib. Last speaker is Dr. Pankaj Goyal, who's a consultant, Department of Medical Oncology at Rajiv Gandhi Cancer Hospital, Delhi. Over to you, sir.
Thanks a lot, organizers, and thanks a lot, Pfizer, for giving me this opportunity to discuss this real life evidence on the use of cyclin inhibitors. So we have two of the studies which are international studies, and one is from India only, and that happens to be from our institute, Rajiv Gandhi Cancer Hospital. So just a minute, I'll share the slides. So navigating management with CDK4/6 inhibitors, optimizing treatment using real world evidence. So we are very well aware of this fact that as per the Globocon 2018, breast cancer happens to be the new leading cause of new cancer cases and cancer-related deaths in specifically the females, mostly in the developing cities. And in India, breast cancer now ranks first in cancer incidence and mortality for women, and also for both sex combined. As we can see, the number of new cases are around 27%, which is one of the highest among all the cancers if we see. And roughly 30% of women who have early disease will develop advanced or metastatic disease in their lifetime. And 6 to 10% of all patients with breast cancer present with MBC at time of initial diagnosis, the figures might be a bit high in the Indian context. And this is the landscape if we see. Most of them are hormone positive, 61%, and others are more or less equally divided in the other three subgroups. And I need not stress much on this. This is a well-known fact. We have virulent and the indolent ones, the triple negative with the short PFS, short OS, and the indolent ones which are hormone positive and endocrine sensitive, which live longer. So this is cyclin D1 and CDK4/6 are downstream of signaling pathways that lead to cellular proliferation and regulate the G1S checkpoint. So these cyclin inhibitors basically inhibit the initial phase of the cell cycle, thereby inhibiting the proliferation of this cancerous cells by thereby interacting with the retinoblastoma gene. So this was one of the first in class CDK4/6 inhibitors, and I think all of the oncologists available have most of the experience with this particular drug. Palbociclib was the first drug to come into the market, and it is an orally selective inhibitor of CDK4 and 6, inhibits cell proliferation and cellular DNA synthesis by preventing cell cycle progression. And low nanomolecular concentration block the retinoblastoma phosphorylation, including specific G1 arrest in sensitive cell lines. It also inhibits proliferation in cultured and xenografted leukemia, myeloma, breast cancer, and colon cancer. However, till date, I think the use is more or less restricted to CA breast. So indication, Palbociclib is indicated for treatment of hormone receptor positive, HER2 negative, locally advanced or MBC patients in combination with aromatase inhibitor or fulvestrant, depending on what line we are using it. And both in pre and perimenopausal women, the endocrine therapy should be combined with a LHRH agonist, or you need some sort of ovarian suppression, whether it's medical or surgical. So these are the various studies, overview of select real-world studies with Palbociclib. One is the IRIS study, then is the Flatron study, Polaris study, and the expanded access program. So 3 of them happen to be the retrospective ones. Polaris is the prospective study. So this IRIS was a multi-country study, and Flatron was basically from US. So touching the Flatron, this was a real-world retrospective analysis of electronic health records of postmenopausal women with hormone-positive breast cancers who were initiated on Palbociclib plus letrozole. So they had multiple sites in US, 280, more than 280 cancer clinics, and this was a very large study with 2.2 million active patients. So these were the patients' characteristics. If we can say the total population was 772, and letrozole alone 658. And median, if you see the age group was as expected 60 to 70 years of age, and most of the women were in the age group of 50 to 74. So if you go through this graph, they look more or less balanced, I should say, the way we see in a prospective study. However, we cannot have an exact balance. So that is the drawback, and that is the charm of the real world studies, that you will have actually the practical experience on the outcome of these drugs. So this was a 2-year OS among patients who received Palbo plus Letro versus letrozole alone. And that was 80% versus 63.9%. So if you see this, the median PFS increased from 11.9 months to 19.7 months. And overall survival as compared to 40.3 months was not reached in the study arm. So as expected, PFS doubled the way we have seen in the various trials what we have gone through. And post PSM real world, if you see median follow-up of 24 months, again, median PFS shows doubling from 11.9 months to 20.2 months, and survival again 43 months, and not achieved reached in the study arm. So as per the subset analysis also, even in the real world, we could see that all the arms were basically favoring the Palbociclib. So these were also the extremes of ages, even in the patients more than 70 years, where we had hiccups initially, whether that will be tolerated or not, but these patients also tolerate that quite well, may need some dose reduction in some of those patients. And irrespective of the performance status, and even in the performance status, more than one, they have been utilized and the efficacy is still maintained. And as per the volume load, metastatic disease or not, and then the much talked about whether bone only disease really needs the cyclin inhibitors. So do not compare to fulvestrant, but still the comparison of endocrine therapy versus cyclin combination again favors the palbociclib combination. So conclusion, in the real world setting, first line palbo plus letrozole is more effective than letrozole alone in the heterogeneous population and among various patient subgroups, with the hazard ratio of 0.54 for OS. These data complement the superior clinical efficacy observed in CDK4/6 inhibitors in the randomized clinical trials. Then there was the IRIS study, which was the retrospective study, which was in multiple countries, USA and Europe. This was again a retrospective study, analysis and treatment and clinical outcome among patients receiving Palbo. And these was two separate analyses, IRIS Europe and IRIS US. And if you see, the data actually replicates, thereby we have all the more confidence in the results of this study. As we see that IRIS study, the PFS rate at 12 months was 84 months, at 24 months was 64 months. And same was in the Europe. And OS rates also were impressive, 95% in US and 90% in the 24 months. And same, more or less, it was same in the IRIS Europe study. So the endpoint, the complete responses were on the tune of 11 to 21%, and partial responses were 60%. Stable disease 13%. So overall response rate was 80% and 84% respectively in US and Europe. So clinical benefit ratio was quite high, 93 to 96%. So, sorry. So this is again Imran's real world insights study in US and Europe, where we can see that we have a dependable PFS and OS, where we have this 24 months OS of 85 months. So response rate in patients with palbociclib plus fulvestrant, when it was used in mostly in the second line, again we can see partial response and stable disease and complete response. Partial responses were 65% and complete response were again 8.5%. Clinical benefit ratio again 85%, which was quite impressive in the real world study as well. So to conclude, in this first real world assessment of clinical outcomes in US patients with hormone positive MBC on palbociclib plus AI combination or a combination with fulvestrant, this demonstrated favorable effectiveness in terms of progression-free survival and survival rates, and high proportion of patients initiated on the full dose of 125 mg per day, and low rates of dose reductions were needed. So real world response and clinical benefit rates were similar to those in the clinical trials. And ongoing studies are needed to deliver mature clinical outcome data beyond 12 or 24 months. Then was this Madeline study, which was again a multi-center study, where they had analyzed the chances of having neutropenia. So 152 neutropenic events were experienced among these 62 patients, and 28% of events were grade 1, and grade 3 and grade 4 were around 34-36%. So mean duration of neutropenic events across all grades was 87.5 days. So evaluation of the patient reported outcomes, no association between neutropenia and quality of life, as we can see that the quality of life indices remain more or less same, irrespective of the patient is having a neutropenia or not. And even I think everyone has experienced over this past few years of experiencing the palbociclib when it is used in the patients. More or less, it's a paper toxicity. You should say that the patients do have neutropenia, but hardly ever we will find they are symptomatic. So they are usually, when we are checking the CBC counts as recommended, then I hardly see any patient going into sepsis or neutropenic complications. So the quality of life is maintained. Then almost half of the patients experience neutropenia at some point, and the patient maintained quality of life, and daily PROs collected suggest a low level of pain fatigue that actually does not change substantially over time, regardless of the experience with neutropenia during the study. So this was a treatment satisfaction questionnaire. Various questions were asked from the patients, depending upon whether they were comfortable with the tablets and whether they are taking them regularly. What expectations are they having? Whether it will stop the cancer or it will eradicate the cancer. So these were the treatment satisfaction rate, as we can see, according to as per all the parameters tested. 92% reported the side effects were as expected or better than expected, because usually when we start treatment, we tell them, okay, this is some tablet which works something like chemotherapy or working on some particular cell cycle segment. We tell them about chances of having neutropenias, less cell count, and all the standard complications. But when they actually take it, not many have any of such problems. So most of the patients are actually happy with the outcome. So most patients across all countries felt their treatment would help them return to a normal life. And that does happen, as we have seen that patients do return to their work. And nearly all felt that the medication benefit had met or exceeded their expectations. So this was the Indian experience, was from our hospital, real world evidence of Palbociclib use in MBC. So largest real world data from Indian population as such, where we had clubbed patients from RGCI and BLK. So we had 188 odd hormone positive patients who were initiated on either Palbociclib plus aromatase inhibitor or Palbociclib plus fulvestrant between 2017 and 2020. So premenopausal, they were 108, and postmenopausal 80 patients. And stage of presentation mostly were metastatic, and like brain metastasis was present in 9% of the cases. And most of them had less than 3 sites of metastasis. And they were also subdivided on the basis of visceral metastasis or bone-only metastasis. So median PFS, first line we had seen around 22.2 months. Second line we had median PFS of 12 months. So this was more or less touching the studies subgroups what we had seen. But in real world, you do take a patient who are actually not really taken in the studies as such, like PS2 patients will be taken, or patients with brain metastasis will be taken if they are mildly symptomatic also, depending on whether they have been radiated or not. Overall response rate was quite impressive, 80% for the first line and 50% in the second line. So 10% patients had grade 3 or 4 adverse events, and 20% patients had neutropenia, which is grade 3-4, while not any patient had any febrile neutropenia. So again, from this study, we could conclude that this real world data of Palbo use in Indian population was similar effectiveness to previously published real world evidence and is standard of care in first line and second line treatment in hormone positive subgroups. So dose reduction was usually not required. There was few patients who did need a dose reduction, around 41% of patients in this, although in further analysis, when other patients were added, this actually has come to a bit lower. So partial response 14.9%, stable disease 17.6%. And many of these patients actually had also been exposed to chemotherapy first. So that was also considered. And half of the patients did have exposure to chemotherapy. So Palbociclib in hormone positive MBC, this was from Amit Rautan et al. Multi-center retrospective study from southern India, 133 patients with hormone positive or negative MBC, and 83 in the first line setting and 50 in the second line setting. Median age was 56 years. So again, from this, we can see that the patients had a median PFS which was not reached. Maximum follow-up was 38 months. De novo metastatic or relapsed had 18 months in the comparator arm, and in this particular combination, it was not reached. So in second line PFS, it was 14 months, but in first line, we can very well understand that the PFS was anyway way beyond more than 18 months, as it is not reached, and OS was also impressive. So neutropenia in 75%, thrombocytopenia in 19.5%, and grade 3 neutropenia was 23%. Again, they had no febrile neutropenias. 30% did have dose delays, and 8% had dose reduction. So again, to conclude, it resulted in similar efficacy and safety in Indian patients as Paloma trials, and neutropenia happened to be the commonest side effect as expected, which was uncomplicated and easily managed. So this was the retrospective analysis in naive patients who were hormone positive at a Chennai center. Patients who had progressive while on hormone therapy and those who received Palbo as a second line were excluded from the analysis. So median PFS 18 months, more or less what we had seen. Median OS not reached, and 1 year PFS 73%, 1 year OS impressive 90%. And these were the response rates: complete response in 4%, four patients, partial response in 4, stable disease in 5. So to conclude, complete response was seen in 19%, that is 4 patients, and none had progressed at the time of follow-up. 24% patients required dose reduction due to fatigue or mucositis, but they did not discontinue the treatment, had no unusual, unexpected side effects, even in the patient with brain metastasis. Median PFS in the study was 18 months as compared to 24.9 months in the Paloma trial. This reflects the fact that real-world outcome is usually inferior to the reported clinical trials because of diverse type of patients which we take in the trial. So this may be due to inclusion of all comers, decreased compliance intake, and shorter follow-ups basically. So practical consensus, this is the take-home message that in patients with MBC, available evidence does not support local regional treatment. The decision should be individualized based on patient's tumor and characteristics. Endocrine therapy rather than chemotherapy is preferred in patients with these type of patients. Chemotherapy may be offered if patients are in obvious crisis, in obvious visceral crisis. A combination of AI and Palbociclib should be preferred first-line therapy, and premenopausal women need to undergo some sort of ovarian ablation, whether it is medical or a surgical. And at present, ESR1 testing is not recommended in routine clinical practice, and I am not aware of any of the practitioner who is trying to follow the ESR testing to decide the first-line treatment. The first-line treatment remains same irrespective of whether it's positive or negative. A combination of fulvestrant and Palbociclib should be offered to patients who have progressed on AI. So these are the questions, has Palbociclib changed the treatment paradigm? So prior to early 2015, there was no treatment option and little was known about patients' experience. So this data actually tells us of this drug Palbociclib letrozole, and real-world data complement the superior clinical efficacy observed in the various randomized clinical trials. Safety, it was as expected, no untoward side effects were seen. So we have to monitor the complete blood count and every 2 weekly for at least 2 months, and then we can switch to monthly testing. Quality of life was very well maintained, irrespective of the neutropenia chances. And final word, the Palbociclib represents a significant advancement in the care of hormone-positive HER2 MBC first-line therapy with manageable adverse side effects, restored quality of life for patients with less and later use of the chemotherapy regimes. With that, I'll conclude. Thanks a lot for the patient hearing.
Thank you so much, sir. We'll now move on to our next session. This session is sponsored by AstraZeneca, and our topic is redefining the management of HER2 negative early breast cancer in the era of precision medicine. And our speaker is Dr. Amit Agarwal, Director and HOD in Medical Oncology Department at Fortis Hospital, New Delhi. Over to you, sir.
Hi, thanks. So this is sponsored. I hope that the slides are sponsored by AstraZeneca, but the views are all mine. Thank you. So we will talk about a set of population which is HER2 negative. So it will comprise of both ER/PR positive population, and it will also comprise of triple negative breast cancer. That's a substantial number of population. And the idea is what has happened in the last 6 months or a year or so. This is our agenda, background, Olympia, and the rest of the data set. Small talk about early breast cancer. We know that the breast cancer can present either early or late, and there is no great surprise in talking that the patients who will get diagnosed as an early breast cancer would have a high survival rate. No great shakes about it. And this is the topic, this is the area of concern also, because still getting diagnosed as early breast cancer, a lot of patients would still not survive. So we will talk about Brca mutation first. So this is one of the few things which have happened in last 6 months or 1 year. If you look at an unselected population, and to remind you that we have our own Indian data set on Brca positivity in ovarian carcinoma, and anywhere between 20% to 25% of patients are Brca positive. If one were to test for allied genes, possibly the positivity will crop up to something like 45% or so. What about breast cancer? So the data coming from the Western world is very clear. Talking about BRCA1 and BRCA2, approximately 5% of patients possibly represent the germline BRCA mutation. If you were to possibly do testing on somatic sampling also, I assume an incremental benefit of 1%, 2%, or an incremental number of 1%, 2%, or 3% would add. But that's a data set from Western world. What about India? So far, we haven't had any major data set. I could come across two major data set, of which the data set on the left is from AIMS, from Abhinil Mittal, and the rest of the team from our AIMS group. And I congratulate them for a wonderful data set. This for most importantly for consecutive patients. So these were not selected population, as was the data set, our own data set from ovarian carcinoma. And it was surprising because what we thought was 5% in the world, and if you look at BRCA1, 2 and allied genes, you could see in this that around 18.64% of population was positive. So that's a very high number, and that's not very far away from BRCA1, 2 mutation in ovarian carcinoma. Another data set in the selected population of triple negative, and looking only at BRCA1 and BRCA2 and not allied gene, is still a high number of 13.6%. But to my mind, this consecutive patient, a good number of 236 patient, gives us a very good value of what to tell our patient or what to expect, that 1 in 5 patient would have a BRCA1 or allied mutation, opening up the Pandora's box of who to be tested and who not to be tested. Is there something special about BRCA? Well, they usually diagnose at younger age. They tend to be of higher grade. They have a potential for more CNS metastasis, and the contralateral breast has a higher incidence compared to an ipsilateral disease. The other quote remains controversial. Do they have a higher risk of recurrence? I think the biggest data set come from UK, which suggests that in fact, if you look at 3 years disease-free survival in an early breast cancer with BRCA positivity, they may actually have an advantage, although after 3 years it levels off. So the BRCA mutation may be a therapeutic advantage, bad for the family history, but it may not be a disadvantage to that patient per se for that particular breast cancer. So these are the patients who should be tested, and I think this is extremely important. Our index to get a BRCA mutation is getting lower and lower because it was initially non-therapeutic, but now the therapeutic options are opening up in an adjuvant setting and a metastatic setting. So I think more and more patients are getting BRCA1 and 2. We still have a controversy and confusion about should we be testing for allied genes or not, but I think in an appropriate setting, as in guidelines and as for therapeutic use, at least BRCA1 and BRCA2 mutation should be tested. I imagine and wonder that more likely allied genes will become part and parcel of requirement of although often we do it. So moving on to from BRCA, we'll move on to Olympia, which is about olaparib only. We have had many adjuvant, pseudo-neoadjuvant, neoadjuvant and adjuvant trial, which include immunotherapy, olaparib, abemaciclib, capecitabine, carboplatinum. So obviously some of the questions have been partly answered, but not all of them have been answered. So about olaparib, for a germline positive population, so there are no somatic mutation positive, non-stage 1, non-stage 4 disease, and they have their own defined criteria of how to calculate the high-risk population from the neoadjuvant TNBC group, from an HR positive non-PCR group, and a complex method, which the next slide will also show. And in an adjuvant group in triple negative, all more than T1 or node positive, or an HR positive, you have 4 positive lymph nodes. So they're so complex method, and there's so many other trials coming up. I guess we need to keep on coming back to these trials to remember which is the group as per the trial set. And you could see that IDFS, invasive disease-free survival, was the primary endpoint, and the drug was given for a year in a 300 milligram BID dosages for a year. Now that's the CPS, which is clinical pathological stage, and also including estrogen receptor status and under nuclear grade to come out to a score in an HR positive population. We have already discussed about a complex way of defining high-risk population, both the neoadjuvant group and an adjuvant group. Suffice to say that it did meet its defined endpoint, which is invasive disease-free survival, and at about 1 year, the treatment was stopped. The gap between the two arms is maintained. In fact, seems like that the gap is increasing, and there's an incremental improvement in IDFS of approximately 8.8%, and that is statistically significant, leading to approval for adjuvant olaparib in an appropriately selected population. There is hardly any group which is not benefiting, but you could see that this group had very few patients who have been treated with platinum, and there's an upcoming role of platinum in a neoadjuvant setting, at least in a triple negative patient, and very few patients had HR positive disease. So this trial was largely led by patients who were either triple negative and haven't had platinum. But from this subgroup, one cannot analyze that previous platinum receiver or an HR positive population cannot be treated with adjuvant olaparib, but one can also say that the number of patients in this group are too small. The overall survival data is not yet mature. As you can see that most of the patients are living, and that's a huge, great number in the population which is governed by high risk early breast cancer, the bad ones, and the population which is largely triple negative and have not received platinum, but that will not be a major issue. If you can see at 36 months, most of the population, more than 85% of population, even in the placebo group, is surviving. That's a fantastic number. That's a very great number. So the overall survival difference is there, 3.7%. Looks as though it is statistically significant, but at this point of time, the desired PSP value was 0.01, so it cannot be called as statistically significant. Time will tell whether the trial meets its overall survival and whether the investigator will report overall survival, particularly if there's an absence of overall survival because they've met their endpoint and there is an approval already. In this context, one should remember that there is a role of capecitabine in adjuvant setting in which there has been an overall survival benefit. Would you use an olaparib or would you use a capecitabine is a matter of discussion. How would you combine the two together is also an issue. Olaparib is not a very gentle drug. You look at all the pink bars here and look all the placebo bars here. Some of them may be reported by the investigator as something which we could handle, but we know a continuous life with a nausea and a fatigue and an anemia is not an easy life, and we have used olaparib and we find that olaparib may not be as bad as chemotherapy, but it is not a very easy drug. We talked about carboplatinum and we'll talk about brightness. So the brightness which has been updated, and that slide set is not there in this set of set. There was an arm where in triple negative population which had paclitaxel or a paclitaxel plus carboplatinum, and third arm had veliparib. Please note the trial was for this versus this, and what we are talking today is this versus this. So to say the arm wanted to check the role of veliparib in addition to paclicarbo, and it failed. But I think it was surprising. They were surprised by the fact, and they therefore wanted to talk about carboplatinum, but that is how the data set is. So the difference between the two arms was not statistically significant. What came was that a paclitaxel carboplatinum and a non-carboplatinum, non-veliparib arm, there was a significant difference in pathological CR rate. Now this is the same or perhaps more difference than we saw in Keynote 522 and a significant achievement of pathological CR rate. And you can see that absence of platinum does very badly for event-free survival, and these curves are significantly different and they are clinically different as well, clinically meaningful. But what we don't see is an overall survival benefit here. It seems that most of the curves are largely merging with each other. But what is exciting is that even in this trial set, if you look at about 80-85% and look at 60 months, at about 5 years, around 80% of population are surviving, and these are triple negative populations. So that's very exciting. It seems that we can clearly improve EFS. Now there could be a debate between a purist for overall survival and EFS, but I in my own thought process, ability to prevent an event in an adjuvant setting is a meaningful goal, but one could have a debate on it, an argument about it, but I think it's good. Capecitabine, as I alluded to before, has actually revolutionized our treatment. If we manage to give neoadjuvant chemotherapy to triple negative patients, because the surgeon will often not let us do it, then in that case, and if you have an inability to achieve a pathological CR, I think in our own practice, capecitabine has become rather standard of care, and we have been so extremely happy with an 8% incremental benefit on overall survival. And please note that we haven't yet seen that with either a Keynote 522 or even with the Olympia A, and a pretty good clinically meaningful disease-free survival in a triple negative population. There is some benefit in HR positive, but it seems that the benefit is largely driven by a triple negative population. So the Japanese would say that use it in HR positive, but I think this is how it is approved, and this is how we are more inclined to use in a triple negative non-PAT CR achiever. I think the data set is clear to use it. So this was a good SES6001 trial. The patient who did not receive neoadjuvant chemotherapy had adjuvant chemotherapy, and there's always this dilemma: can we use the CREATE-X data set for that? But we did not see who got PAT CR or who did not get PAT CR. So this is the trial which comes to a help to a degree. So this is the Chinese trial on a 434 women, and either they receive capecitabine at a dose that we can give 650 milligram per meter square, compared to a CREATE-X trial in which the dosages were such that we cannot give, and we often optimal dosage according to the trial set. This showed a significant, approximately 9% reduction in the improvement in disease-free survival, which is statistically and a clinically meaningful thing. The other difference is they gave it for a year. So if you have a triple negative patient who did not get neoadjuvant chemotherapy, so it is not possible for us to answer the question of PAT CR. I guess this trial can be used. One can argue about Chinese trial, but one can also argue about the other trial being Japanese and Korean, so both may remain not applicable to us. The CALGB trial is an old Hyman Must trial on more than 65-year-old population. They wanted to see a single agent chemotherapy with capecitabine with either an older generation treatment of CMF or AC, as taxanes have largely become a standard of care. And it reciprocated the old data set that a single agent capecitabine cannot compete with CMF or AC chemotherapy. The curves may separate a bit further if the patient is eligible for taxane and can tolerate taxane. Then these curves may go further apart, proving the fact that if the patient needs chemotherapy, therefore single agent capecitabine in that cases would not be eligible, will not be an enough thing. But if I remember correctly, a population of ER positive, the curves were not too far off, but I think that was subset analysis, cannot be drawn any inference from. The most talked about, and I would still say confusing trial. We all know how the trial was. Organized. We all know that PCR and investigator assessed EFS was the point of contention. How they assessed it, very much talked about. We have an early data analysis at 18 months, and we have late data analysis or later on at 36 months. The trial set, this set doesn't show that. It measured one of the primary endpoint, a robust 13-14% improvement in PAT CR. It resulted in early separation of EFS curve, and we all know that the curve separated further at 36 months, which is approximately 3 years, by which time most of the relapses in triple negative breast cancer are expected. So it did meet its endpoint of event-free survival. PAT CR, there has been an update recently. Very few mortalities so far, very exciting, hardly any patient dying, less than 10%. It did not meet its OS at this point of time. Would they meet OS at some point of time later? Would the investigator decide to report OS if the OS is not good? Whether one would be happy with EFS or whether one would be happy with overall survival only is a matter of discussion. But the sensitivity analysis and subgroup analysis did not show any major differences of one group over the other, including PD-1, although there was some suggestion that people who had a high PD-1 positive disease, PD-L1 positive disease, possibly had a higher response rate, possibly may have been driven by that, but one cannot be sure. It also opened the Pandora's box of, if they achieved a PAT CR with pembrolizumab, then what are you going to offer them? Are you going to offer them pembrolizumab? If they don't achieve PAT CR, then what are you going to offer them? Are you going to offer them pembrolizumab? You're going to offer them olaparib in an appropriate case, or you're going to offer them capecitabine, which we are very used to, and that is something which gives overall survival benefit. Another data set was IMpassion 031 with atezolizumab. The best part about this trial was that it did not have carboplatin, raising the question that what was the contribution of carboplatin if we do a cross-trial comparison. You can see that there was a almost equivalent PAT CR improvement. From there it was 50 to 65, and here it is 41 to 57, but the delta is same for PD-L1 positive and PD-L1 negative. It did not meet its overall survival benefit, which we cannot say about Keynote 522 also. The delta remains not very different from each other. from what I remember, and I could be wrong, is that IM patient 031 also did not meet its EFS endpoint, which was met by Keynote 522, but I cannot be 100% sure about. If you look at this drug like olaparib, it is not an easy drug. These two curves are not equivalent. Here it is from 0 to 50 and here it is from 0 to 20. So this looks bigger. But even if you look at infusion reactions, hypothyroidism, rash in 50% of population, 7 to 10% patient developing hypothyroidism is not easy. These autoimmune disorders can be potentially life-threatening. Look at Guillain-Barré syndrome. Can possibly require treatment forever. So there needs to be an honest and open discussion with the patient and the family of what we are offering at a huge cost and what is the potential benefit. Please note that in the keynote 522, there was 7 deaths compared to 1 death. You may or one may not ascribe it to pembrolizumab, but the data is there to see. Most of them in neoadjuvant phase, possibly the combination of chemotherapy and pembrolizumab is more toxic. But having said so, 7 deaths cannot be ignored. 1 in 4 patients in these trials, both the IM patient 031 and Keynote 522 got out of the trial because of it. That's a rather large number to get off. We shift the gear. We talk about hormone therapy, adjuvant in high-risk population like olaparib and capecitabine, but this time in ER/PR positive populations. So we have 3 trial set. One is Monarch E, Penelope B, and Pallas. One of them is positive, which is Monarch E, in their own defined subset of population, either based on clinical pathological risk or based on Ki-67. They were offered standard of care endocrine therapy, or they were offered abemaciclib for 2 years. Remember, abemaciclib for 2 years is not an easy drug, and their primary endpoint was invasive disease-free survival and host of other secondary endpoints. It got approved for a very odd indication, solely entirely based on Ki-67, but I think there is a lot of criticism going on that. But it met its endpoint of approximately 2 to 3% of IDFS improvement, and you can see it is starting 24 months when you stop abemaciclib, both in invasive disease-free survival and relapse-free survival. I'm not myself convinced about giving 2 to 3% of this benefit, which cannot be ignored, but that's not huge. And at coming at A, the financial cost, and coming at B, significant toxicity that I observe giving abemaciclib in metastatic setting. It is not an easy drug to offer. And yes, we agree that with an additional follow-up, there was a benefit which was well maintained. This is an enlarged view from 70 to 100, and you could see approximately 3 to 4% of, or 3 to 4% approximately of incremental benefit could be observed. So possibly I would use this drug for extremely high risk patient, but I don't find this drug to be an easy drug. But I do agree that many other investigators and my colleagues felt that abemaciclib is not very difficult compared to ribociclib. My opinion is very different. Difficult to live with 83% grade 1 diarrheas, 39% fatigue for 2 years, 45% chances of neutropenia even if not febrile, 34% chances of abdominal pain. These are not easy things to live for 2 years. But yes, 3 to 4% of IDFS advantage cannot be refused. Now we have 2 data set with palbociclib, which is failure. Now they have data set with their own criteria of high risk patient. The first trial gave it for a year with standard of care, could not achieve invasive disease-free survival benefit compared to Monarch E or an overall survival. We don't yet have a data set of overall survival for Monarch E. Their second data set was Pallas, in which they gave it for 2 years. And even after giving 2 years, there was no difference between invasive disease-free survival and distant relapse-free survival. There's a discussion about whether 3 week on, 1 week off is the reason you don't have a continuous CDK4 inhibitor challenge. There's a discussion about how they chose their highly high-risk population. There's a discussion about only 1 year of palbociclib, is it enough or not? There's a discussion about the fact that these 2 drugs may be different. Having said so, not easy. Even if you could give the drug for more than 70% dose intensity and duration, you still do not find the benefit. So either it's the population or the drug, difficult to answer. But yes, palbociclib is a much easier drug to tolerate than abemaciclib, but can't use, there's no data set to support. One another question that they answered well. That answers to a degree about question of adjuvant CDK4 inhibitors vis-a-vis olaparib. There is some indirect evidence coming up that patients who are BRCA positive and ER/PR positive, they may not be the best candidate for CDK4 inhibitor. It seems that CDK4 inhibitor doesn't work very well. In this population, they did not find any incremental differences with CDK4 inhibitor, suggesting that BRCA positivity does not reduce the efficacy of CDK4 inhibitor. But I think there is data set from Shahina, another group, which is showing that if you have a BRCA positive tumor, they may not respond very well to CDK4 inhibitor in metastatic setting, and there may be an implication of such an adjuvant setting, but at this point of time, too early to answer the question. Adverse event, we are all clear about palbociclib, a lot of data set discussed by Dr. Goel. We have all handled palbociclib and ribociclib. Conclusion, there has been a lot happening recently. I think the great information is Braca, and I congratulate the AIMS group for giving us such a nice data set, telling us about 18 to 19% Braca positive and allied gene positivity that gives us substantial confidence of how to deal with the patient. We do have benefit with Olympia. We do have benefit potentially with pembrolizumab. At this point of time, atezolizumab cannot be considered as success because the PAT-CR cannot be considered success. Some kind of a meaningful survival data set will always be required. We have a data set possibly with carboplatinum, and there are people who are for and against it. We have data set with the adjuvant CDK4 inhibitor, particularly for abemaciclib. I think these are rapidly evolving strategies. And in view of these, I think our existing therapeutic armamentarium has changed a lot over last 6 months or 1 year. And I think the way we practice now is way different from the way we practiced last year or so. Thank you.
Thank you so much, sir. With your permission, we'll move on to our next session. This session is sponsored by Eli Lilly, and I invite our chairperson, Dr. Advani, sir, to please say a few words. Over to you,
good evening, colleagues. I'm sure you are going through a very tough information coming out with every good speaker. And now we are going to discuss about a very important topic which has changed the landscape of the treatment, particularly for the hormone receptor positive and HER2 negative patients. The way it has changed, both for metastatic disease, new or recurrent disease, has really amazed all of us at how today we are getting the responses. Of course, we have many CDK4 and CDK6 inhibitors. One of them was the palbociclib, then came the ribociclib, and now we also have abemaciclib. And abemaciclib is the one which has got very clear-cut characteristics in the sense that one, it has continued throughout without the break period. And therefore, the title we have kept is a cancer does not take a day off. Then why should CDK4 and 6 inhibitors? What it means is that by continuing the CDK4 and 6 inhibitors, the effect will persist. And this can be continued with abemaciclib because it does not produce severe neutropenia as compared to the other palbociclib and the ribociclib, which can produce severe neutropenia and therefore needs the interruption. Of course, there are many other differences. And today we have a very learned speaker, Dr. Bharat Vaswani, who is going to talk to us in terms of clinical case presentation, that why I choose abemaciclib for my patient with HR positive, HER2 negative, metastatic breast cancer patient with poor prognostic. I'm sure all of us know Dr. Bharat Vaswani well, and I would like to hand over the mic to him.
Good evening, sir. Thanks, sir, for a kind invitation. You have been a father figure for each one of us. Let me thank Lily and let me thank Dr. Hemant sir and his team for the kind invite. Now this is my disclosure. Next slide. Next slide. Yeah, so I am discussing one case regarding a specific clinical scenario. Of course, these are real life cases, one of me and one from Dr. Ankur. I would like you to remember the timeline because that is where the gist of the total case is all about. Now, this was the first case, the 50-year-old female diagnosed as carcinoma of breast in June 2019. Please remember, June 2019, it was locally advanced to start with. So there were primary lesions with multiple axillary lymph nodes. So as per as protocol being locally advanced, we gave neoadjuvant 4AC followed by 4 docetaxel followed by a surgery, which was a right modified radical mastectomy. Post-op, a strong ER/PR positive 8/8 Aldrich score, HER2 new negative. She completed her radiotherapy in January 2020. Now she was started on letrozole after checking her FSH and estradiol. July 2020, so 6 months post-op, she was absolutely normal. January 2021, she presented with fatigue, exertional breathlessness, upper back pain. Now, probably because of them insisted, we did a PET scan normally, but to our surprise, we found multiple mediastinal lymph nodes, right upper paratracheal, aortopulmonary, subcarinal, and hilar. So there were mediastinal lymph nodes. We did an endobronchial ultrasound guided biopsy because we thought it could, since it was so early, we needed to rule out tuberculosis. We did a biopsy. To our surprise, it turned out to be recurrence. We rechecked our ER/PR because of early relapse. Still ER/PR strong positive 18%, HER2 negative, Ki67 of 20%. So if I have to summarize this case, it was a case of CA breast post-op with primary endocrine resistance. I will like you to remember what is exactly a primary. So a relapse within 2 years of the start of adjuvant hormonal therapy is supposed to be a primary endocrine resistance. So a early relapse patient. The patient and the attenders discussed about advanced nature of the disease, guarded prognosis, palliative intent. We did our laboratory parameter including creatinine, LFT, it was normal. Next slide. You can see in diagram first and there, you can see the arrows, there were multiple mediastinal lymph nodes, early relapser. Next slide. You can still see in these images and you can see the entire body and see the mediastinal lymph node. Next slide. Now, when we talk about hormone receptor positive, HER2 negative metastatic breast cancer, what makes a cancer bad? There are multiple surrogate things. It is for all purposes, these are 4 or 5 things that we need to remember, which tells us the aggressive inherent nature of the disease. The most important, according to me, is the early time to relapse following treatment. So either we take it in an adjuvant, very early relapse, or in metastatic, if we go ahead with a single agent AI in the first line, relapse within or progression within the first 6 months of treatment. The second include visceral mets, including liver mets, a grade 3 tumor, a negative PR, and I may add on a young patient or a premenopausal. So these are all the things indirectly tells us the aggressive nature of the disease. Next slide. Now comes my question. Now, what is the next treatment? So will I start with a combination of aromatase inhibitor with the CDK4/6? We have a data with fulvestrant with CDK4/6 also, or our old friend chemotherapy or any other. In this, I like to welcome my fellow panelists, Dr. Ankur Bahal, my close friend, Dr. Kripa Bajaj sir, and Dr. Ashish Kaushal sir. Sir,
I think Dr. Bharat, since this patient has progressed on AI and the disease-free interval was 1 year or so, to be very precise, and so next option is fulvestrant, and along with one of the CDK4/6 inhibitor, and on the board we have Palbo, Ribo, and Abemaciclib. And to review the subset analysis of these Monarch, Mona Lisa, and Paloma trial, we clearly know that those patients who have progressed on a endocrine therapy, which comes into a resistance, whether primary or secondary, in view of adjuvant or a metastatic second. So clearly, Abemaciclib and fulvestrant has that survival benefit in the form of PFS and OS. And if we have to choose between one of the CDK4/6, I would go with Ramivan along with fulvestrant for this patient who has progressed early on adjuvant therapy.
Wonderful. I like to take the other two panelists just for a minute. Dr. Kripa, are you there?
Yeah. Yes, sir. I'm here, sir. Very much here.
Kripa, anything to add on? Ankur sir actually re-emphasized the important thing that I wanted to tell. Anything more to add on? We had two.
No, sir. I totally agree with Ankur, sir, that if it is a post-letrozole and primary endocrine resistance, clearly abemaciclib is a winner compared to other two inhibitors. Ribociclib, there is some benefit is there, but be it response rates or OS or PFS, abemaciclib is better in this situation.
Wonderful. So all of us know, as far as now, I think there is no confusion that if you have a de novo or a hormone receptor positive, HER2 new negative breast cancer, unless in visceral crisis, what we say, even that definition is a bit controversial, we should think of giving a CDK4/6 along with any of the hormone. In this case, since the patient was already on letrozole, the best option should have been a fulvestrant CDK4/6 inhibitor. Next. Now comes the most important question. Ashish sir, we have three drugs available. Started with Palbo, then we had Ribo, and now abemaciclib. $1 million question here. Which is the best partner according to you, along with a hormonal thing in a primary endocrine resistance? Dr. Ashish.
Yeah, but I think we have a data of all these three CDK4/6 inhibitor for this particular setting. When the patient is having progress with the prior endocrine treatment, especially with the aromatase inhibitor, I think the fulvestrant CDK4/6 inhibitor is the right drug. And this particular patient, if you, as for the history I was going through, this patient didn't respond well with the chemotherapy also. The primary tumor, which was 22 millimeter at the beginning, and the nodal disease quite high. Even after giving neoadjuvant chemotherapy, the patient was having the T2 lesion and it didn't respond to the chemo. This reflects a more aggressive biology of this patient. And I think even he didn't respond with the single agent endocrine treatment. So as far as the current data is concerned, all three CDK4/6s are inhibitor. But if you look for the subset analysis, as Ankur was mentioning, the primary resistance is a category where we have having superiority of abemaciclib compared to the rest of the CDK4/6 inhibitor. The magnitude of the benefit, especially in the primary resistance category, I think the palbociclib is not showing results as far as the subgroup analysis, and it's indirect comparison of the studies. But there is some benefit in the ribociclib. But if you look for the data of the abemaciclib, especially in the primary resistance category, I think the magnitude of the benefit is highest with the abemaciclib compared to the palbociclib and ribociclib.
Excellent, excellent, sir. Uncle, sir, on a Monday morning, now there are three. When do you choose Abema? When do you choose Palbo? When do you choose Ribo? If I have to say,
I think
you choose one over the other?
So very rightly said, the Monday morning practice of coming Monday or the previous Monday, whatever it is, I would like to segregate my patient who is a poor prognostic patient among HR positive, HER2 negative patients. So these patients are those patients who have early relapsers on my anastrozole, letrozole or exemestane, the early relapsers who are on a visceral disease, the early relapsers who do not have a bone disease and the burden is too much, and probably the compliance does not say that those patients who have brain metastasis or leptomeningeal metastasis. So if I have to choose between the one of the three drugs, so the disease severity, when it comes to visceral resistance and the early disease, the bony metastasis, the brain metastasis, and more importantly, which subset of patient I'm treating. If treating patient with the existing heart disease or some arrhythmias or some CAD, probably Ribo is out. If I'm treating patient who have been heavily treated with chemotherapy, elderly patient with less bone marrow cellularity, probably Palbo is out. And if my patient is having some irritable bowel or a difficult diarrhea, then probably Abema is out. So I have to choose such patients who benefits with one of the CDK4/6 inhibitors, maximum with that side effect profile, with that easyability, with at good compliance, and moreover, the finances also, which I have to look between Palbo, Ribo, and Abema. So some or one agent excides over another when it comes to finances also a bit. So all these factors are taken into account when we choose all these three drugs.
Wonderful. So if I have to summarize, there are 4 or 5 things what Ankur sir rightly said. Most important is the aggressiveness or the early relapsers. So for all purposes, abemaciclib has the best data in those who relapse early, that is primary endocrine resistant with the best hazard ratio, as I will be discussing. Second thing what sir told is a poor prognostic subset like a liver mets, visceral mets, probably a more what we call as indirectly, not exactly a bone met, but a visceral. In that case, probably a more potent drug. The third thing that sir told rightly was maybe a good advantage when the patient has a brain metastasis. The fourth thing that he rightly said is because depending upon the comorbidity that you may decide. So if you have a failure in a bone marrow or a poor bone marrow reserve, probably this is the better drug to give. So all in all, one of the potent drugs to give, the best data in primary early relapser, that is primary endocrine resistance, and I fully agree. Next slide. So as has been discussed, and I think should not be any controversy regarding this important point, because what we said is this is the best drug in terms of primary endocrine resistance. So as far as the data available, we started the patient on abemaciclib 150 twice a day as per a standard dose along with fulvestrant. Next slide. Now this is the most important slide, and I have been discussing it repeatedly. We know the data of Monarch 2. In all, there was a 9.47 months absolute improvement when abemaciclib was added to fulvestrant arm. But when you look into the primary endocrine resistance, please look into the overall hazard ratio of the trial, 0.75. And when you look into the subset of a patient who are early relapser, this hazard ratio was 0.68. So probably the quantum of benefit was high. In terms of absolute benefit, it was 38 months. Please remember 38.7 months. It was the survival in a primary early relapser. Next slide. Now, when you talk about, you go one slide back, sorry. Previously, Now, when you look about palbociclib in this subset of patients, please remember the primary endocrine resistance was like a no sensitivity to prior endocrine therapy in palbo, that if you see, there was no benefit. So for me, probably, although a different trial, but there was no additional benefit of palbociclib in primary endocrine. You look into overall survival, it was only 20 months. So when I say 38 versus, you can say 20.2. So you obviously have a difference for it. Next slide. Now, when we talk about ribociclib, in fact, this was a presentation in this ESCO 2021. This was an exploratory analysis, not like a predetermined analysis. And when you look into endocrine resistant, it was 0.81, 0.68, 0.81. So probably you may still not, I always say that we should not do a cross trial, but again, when you see the cross trial comparison, slightly better efficacy, a pre-specified endpoint in Monarch 3 versus an exploratory endpoint in these Mona Lisa 3 study. Next slide. So probably, yes, the best drug in this subset without any controversy. So PET scan in January 2021, when we started, there were mediastinal lymph node. 6 months down the line, no lymph node at all. There was a single lymph node which was persistent subcarinal, but there was resolution of the metabolic activity. More importantly, no new lesion. Next slide. You can see the diagram. If you compare with the first one, most of the nodes had disappeared. A small subcarinal lymph node, but yes, it was the activity reduced. Next slide. You can see the same node, but with reduced activity. Next slide. So PET scan that revealed that there was no abnormal soft tissue metabolism post-operative site, and as compared to the scan, there was decrease in the size and metabolism of subcarinal lymph node with resolution of other metabolic lymph node. There was no new lesion. So probably in this aggressive early relapsing subset, the best drug with the best proven efficacious pre-specified endpoint data is abemaciclib, and that was one of the cases.
Dr. Bharat, it's a request. I have a parallel meeting. If you can give me a chance, I can present and then you can take over, please.
Next slide. Thank you.
So I think Dr. Bharat rightly presented a patient who progressed with the mediastinal lymph node, and I have a similar case. The thing about this case is that this patient presented with a visceral crisis when she was on anastrozole. So the question here is that, do the patient which are on visceral crisis actually need chemotherapy, or this CDK4/6 inhibitor who are cell cycle inhibitor, which I believe they are actually a chemotherapy. The process is chemotherapeutic way, the cytotoxicity, which we combine with the endocrine partner, and they can still give us response in that 10 to 15 days or 20 days, and we can still get this benefit. So I'll be presenting a very short case, and I'm apologize for exiting this meeting because I have a parallel international speaker meeting with MSD. Next slide, please. So this patient who was treated with adjuvant chemotherapy, T2N2 disease, AC followed by paclitaxel, and put on anastrozole in July 2019. And then next slide. And then she had in December 2020, which was like after 16 months or 14 months, with multiple bony gross pleural effusion. We did a biopsy, hormone retention, ERPR 8/8, HER2 negative, grade 2, and she required a therapeutic paracentesis for her pleural effusion. Next slide. This is the PET scan, which clearly shows a gross pleural effusion with hilar and mediastinal lymph node and multiple bony. Next slide. Multiple bony, pleural effusion, and a lung metastasis. Next slide. And iliac bone. Next slide. So this was, as we say, within 2 years of adjuvant endocrine partner therapy. So this was primary resistance, and we have discussed with Dr. Kripa, Dr. Ashish, and Dr. Bharat that a primary resistance, shorter time to recurrence, visceral disease, low PR, resistance to chemotherapy, taxanes probably. These are the patients who in various subset analysis of Monarch, Mona Lisa, or Paloma clearly said that these are poor prognostic patients. Next slide. So we have addressed indolent versus aggressive disease. Next slide. So resistance, Dr. Ashish, primary and secondary resistance, do you see in your practice? And do you acknowledge these words in your practice?
Yeah, absolutely. I think we have the data as per the choosing our partners. I think the primary resistance is more aggressive. So I think we target according to the patient's clinical behavior. So if there is a more aggressive biology, especially the time to recurrence is early, I think it will be more aggressive in choosing the partner. So I think I would respect that.
Yes, aggressiveness in the term of primary and secondary resistance do matter when we have to choose the endocrine partner and a next line, second line agent. Next slide. So this we have discussed. Next slide. Next slide. Oh, so I think Dr. Kripa, if we have to choose between 3 drugs, we have discussed in our previous talk with Dr. Bharat. So anything, how do you monitor Palbo, Ribo, and Abema if it comes to your practice in OPD?
So ribociclib clearly first 6 months I do monitor, sir. Palbo as well as Abema first 3 months I do stringently monitor. That's 2 weekly I try to monitor in the first 3 months. If there is no issues with the patient, then I do monitor every 3 months. That should be fine. After 6 months, if there is no issues are there, I do not monitor the patient and I just follow up the patient for the clinical symptoms. And Ribo,
yeah, please go ahead. Yeah, please go ahead.
Ribo, again, 2 weekly ECGs I do prefer at least 3 times. That is like 3 times I do repeat ECGs. If there is no issues are there, I'll not repeat the ECG at all after the second cycle. So that's how I do monitor, sir.
Sir, you are muted.
Ankur, sir, you're muted.
So when do you practice your PIK3CA mutation testing? And if by chance a PIK3CA mutation testing is PIK3 is on a reflex testing, blood or a biopsy is positive, do you prefer alpelisib or you prefer CDK4/6 inhibitor when it comes to a first line or second line? Just a word and then I will exit. Yeah.
Yeah, sir. CDK4 inhibitor, even though if I know the baseline, everyone will try to push PIK3 analysis in the beginning itself. Though it is positive, I try to offer first line only CDK4/6 inhibitor combination with hormone therapy. If it got exhausted, if it got progress of CDK4/6 inhibitor, then I'll use the PIK3 target therapy later, not initially.
So very rightly said, even the guideline says that even if PIK3CA comes positive, enthusiastically before CDK4/6, so we should use CDK4/6 with an endocrine partner, then use the solo trial, alpelisib and fulvestrant. And with this note, I give the stage to Dr. Bharat Vaswani. He can engage with this speakers for a couple of minutes. I have to exit. I apologize. But Dr. Bharat, you can take the stage, please.
No, thank you, sir. Thank you, sir. We understand. Probably, sir, the basis of sir's case was sir was trying to present is patient presenting with a pleural effusion. So probably these are the scenario, and the patient was symptomatic. So should we consider it as a visceral crisis, or should we consider it? So basically,
I would like to add, sir, here. So a visceral crisis itself, it doesn't mean the failure of organ totally. So for suppose different organ will have different analogies. For suppose if it's a liver, grade 2 transaminase itself will take as a failure of the thing. But if lung, it is the other thing. If there is a rapid refilling of the pleural effusion is there, then we do take it as a visceral crisis, but not mere presence of pleural effusion for sure. So it depends on the organ. Yeah.
Ashish, sir. Sir, now probably this patient, after drainage of the fluid, the patient is stable. So, sir, how do you decide in your practice? Because visceral crisis is a term that we basically, most of the trials of CDK4/6, they excluded it. But in clinical practice, probably now with the rapidity of the response that we are seeing also, how do you decide in your practice, sir?
I think you're rightly touching the routine clinical scenario, because most of the patients who are having the pleural effusion, the effusion part has been relieved after the centesis, and most of the symptoms has been controlled. So I think I wouldn't consider this as a visceral crisis, because as we know, it's not only just presence of the visceral lesions. I think it's a more kind of the symptomatic deterioration of the patient in spite of the conservative treatment because of the rapid disease progression. And of course, the laboratory abnormalities also plays in the picture. So once the patient has been symptomatically relieved after tapping, I think I would consider it's a non-visceral disease, and I would be more comfortable in using CDK4/6 inhibitor with hormone therapy as a standard treatment. And another thing I just want to add that nowadays with this combination, we are seeing very rapid response. Unlike we have a concept, it is delay response with single agent hormone therapy. But once you add CDK4/6 inhibitor, I think within few weeks we get the response in the most of patients.
So one more thing that rightly emphasized by Dr. Ashish sir is that when we talk about rapidity of response also, we get these responses when we combine our CDK4/6 inhibitor with a hormonal agent. What we thought, the concept that chemotherapy works faster, probably it is there, but CDK4/6 inhibitor with a hormonal works equally faster, and probably you could give it unless when we say it is visceral crisis. Next slide. This was Dr. Now, this was something that we have already discussed, that how do we choose between the 3 CDK4/6 inhibitors. Sir, just put a word, the brain penetration, the continuous dosing, probably do you think that adds up to the clinical benefit when we give abemaciclib, sir?
So I think choosing the right partner with hormone therapy is we all does based on the patient's profile and the patient preference also. So as we have already discussed, Dr. Kripash does most of the things. I think the patient, the biology, if there is an aggressive biology, like the patient's having the short interval of the disease, primary resistance, more visceral lesions, even with the low PR, I think that's the area where there is a magnitude of the benefit of the abemaciclib is better than the other agents. And as far as the monitoring is concerned, if you see in the elderly population where the ribociclib is little bit, we are more cautious because there is a more cardiac toxicity, and the monitoring is also very much stringent. We need to do that every 2 weekly, especially for first 3 months. We have to monitor the CBC, LFT, electrolytes, and we need to do the ECG. So I think my preference would be more towards the other 2 agents, especially abema and pelvis in the elderly population. But once we come for the if choosing these 2 agents, I think the toxicity would be one of the important concerns. The abema having the diarrhea, some patients, but the incidence is this ranges around 10 to 15%. And most of the patient in our practice, I think it is much lesser. And abema, besides abema, in the pelvis is a more neutropenic complication. So if there is a neutropenia as a concern, I think I would avoid palbociclib in my practice. So toxicity profile in the patient profile will help us in deciding our agents.
Wonderful. One more thing
I would like to add here, sir.
Yeah.
Can I add one?
Yeah, please.
So in my practice, if ever young patient comes, I try to choose between either abema or ribociclib because these 2 are easy to use in young patients. Young premenopausal patients, abema scores better. And also the disease characteristic I do choose. If it is primary endocrine resistant, young patient, lot of visceral disease is there, I require a lot of significant overall response instantly. So at the time I try to use abema. If not, only few lesions are there, they may be, at that time I may incline towards ribo. Though elderly patients, a lot of people are pointing out towards abema, but for me, abema and ribo are not easy to use in elderly people. then maybe at that time I choose Palbociclib 100 mg over other two. And also one more thing, here everyone is discussing about diarrhea. To me, I do start with 100 mg BD for Abemaciclib. There is no diarrhea is there. I do increase the dose and they did significantly well without any complications. For coming to Ribociclib, at least I would say 40% of people I do decrease the dose to 400 mg. In Tata Memorial Hospital, Amali study is going on for Ribociclib 400 mg was 600 mg, because in TMH, almost 40% patients are having a decreased dose because of the rash or transaminitis. It's not prolonged QTC interval. It's the other two which is predominating. So I don't think so. Abemaciclib diarrhea or fatigue is not so significant in young population.
Same as me. In my only one patient had grade 2-3 diarrhea. Remaining 19 are doing well. So I agree. Diarrhea in Indian population is far lesser, as has been mentioned in the studies that have been mentioned. Next slide. We are running short of a fast. So next slide. Next. Everything has been discussed that we decide based on the 6-7 factors. Now, when we talk about Abemaciclib in the poor 6 subset, when you look into the quantum of benefit and when you look into red thing, the benefit is far, the deltas are far impressive. And when we say in the normal low risk subset, again, what Dr. Ashish and Dr. Kripa rightly said is, in a poor subset, the benefit of Abemaciclib, the quantum of benefit is highly impressive, at least 30% benefit or a 30% difference between the two arms. Next slide. So this also has been discussed, the different safety profile. Yes, this is most important here. Talking about hematological side effect, more common in Ribo, Palbo, and a GI side effect, which is slightly more commoner in the Abema arm. Next slide. This is also has been discussed by Dr. Kripa for Abema, for Ribo in the first month twice, and then from third month onwards, it was a monthly thing. One added thing in Ribociclib is we need to see for ECG. Over a period of time, yes, the toxicities are lesser, so the monitoring also reduces. Next slide. Now, one more slide is younger patient. When we talk about younger patient, we have a data in all the three that yes, they definitely work in a younger premenopausal. Of course, we need to add on a GnRH analog. So out of the three, we may choose. In fact, when you look into the data of Monarch, the premenopausal had probably a better, or the quantum of benefit was far better with Abema. Next slide. So this was Sir's slide. So I'm presenting Sir's slide because he had to leave. So Sir, the patient was started on Abemaciclib and fulvestrant. The patient significant pain relief. The hematological parameters were a normal grade 1 diarrhea on day 5 of starting the treatment. Please remember, grade 1 diarrhea, you need not have to modify. It subsided when you have with a anti-motility drug. Next slide. And now you can see the diagram. There is an improvement. You can see the radiological response. The lesions have the activity has started reducing. Next slide. So that was something that Sir discussed. Now, what next after she progresses?
Sir, apologies, sir. We're running short of time.
So should I have 1 minute? Should I conclude?
Yes, sir. Please.
Yeah.
Please.
So probably PIK3 testing has been rightly told by Dr. Kripa. Next slide. I have to see if something is there. So we will not be discussing the next case because of shortage of time. The take home, sir, Dr. Ashish, sir, if you have to summarize, I'll take one take home message from both my lunch speakers. Sir, what do you give as a thing, CDK4/6 inhibitor in your clinical practice? What advice, one final advice you want to give to all the listeners, sir?
So I think all three CDK4/6 inhibitors are there. We have to choose, as we mentioned, based on the patient profile and the toxicity. So I think in aggressive biology, we are discussing this in these sessions many times. I think in the poor risk group, I think my preference goes towards the Abemaciclib, and add on that, this is the CDK4/6, we can give a continuous dosing, and there's a better distribution, even the CNS penetrations is there. So my preference towards I have not many challenges for the diarrhea, which we are discussing, and that is usually seen in first 2 to 4 weeks only. So I think all three are effective, but based on the patient profile, we prefer our agents.
Kripa, last word.
Yeah, sir. Young patients, definitely Abemaciclib is a better drug. Elderly, maybe Abemaciclib low dose or Palbo 100 mg, I would choose, sir.
Wonderful. So let me thank my panelists for a wonderful discussion. Lot of new points that come up, and I thank the sponsor for a kind invitation. Thank you.
Thank you so much, sir. I now request our chairperson to give the summary and closing. Over to you, sir.
Yeah, thank you. Thank you very much. I think all of us have enjoyed the expert talking about the CDK4 and CDK6 inhibitors. It just shows that how every one of us are nowadays absolutely acquainted with all the different molecules. So with these few words, I would like to again thank the organizers for giving us this opportunity. And thanks to Lily for giving us this platform to discuss. Thank you very much.
Thank you.
Thank you so much, sir. Thank you to the expert moderator and the expert panelists. We'll now move on to the ovarian cancer session. And it gives me great pleasure to introduce our session director, Dr. Nitin Kunteter, Associate Professor, Unit Head, Department of Surgical Oncology at Shriram Cancer and Super Speciality Center, Mahatma Gandhi Medical College and Hospital, Jaipur. Sir, I request you to please introduce our chairperson and start the session. Over to you, sir.
Good evening, everybody. Here's Dr. Nitin Kunteter. I welcome all of you for this session. We are brainstorming on ovarian cancer and HIPAC today. And the chairperson that we have today are Dr. Pavan Agrawal, the Senior Consultant at Department of Medical Oncology, Bhagwan Mahavir Cancer Research Hospital, Jaipur. And Dr. Anil Gupta is a Senior Surgical Oncologist at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. Over to you, chairpersons.
Thank you, Dr. Nitin. And now we move on this session. This is an interesting session. And we have a two part of this session. One is a debate, small bit of juncture. And that debate we have include this HIPAC therapy is really useful, or it make a hype in all over globe, or it is very hopeful to the coming era. So we have a little bit debate between two eminent doctors. One of Hope, Dr. S.B. Somsekhar, Chairman and HOD Surgical Oncology Department, Consultant Surgical Oncology, Gynecology Department, and he will speak in favor of HIPAC therapy. And another, Dr. Somsekhar, please start.
Thank you very much. Since the time is very less, I thank the organizers of the ICON. I wish we were in Jaipur in principle physically. Nevertheless, I'm going to speak on favor of HIPAC, not because it is something I do, because all the evidence is in favor of this, including multiple randomized controlled trials. So we will decide at the end of it who is who in this debate. I share a lot of data from Indian Society of Pattern Surface Malignancy, which holds the HIPAC registry of India of over 2,000 ovarian cancer HIPAC, and I'm going to analyze it with 7 to 10 year follow-up. The issue about ovarian cancer is, even what you presume to be early ovarian cancer with capsule intact, there is nothing like that because of the peritoneal current everywhere. All the discomated shutdown cells are in the diaphragm, upper abdomen, lower abdomen, everywhere. They'll all recur irrespective of surgery and chemo alone in 2/3 of the patients. But the beauty of ovarian cancer is, unlike breast or colon or other, the systemic parenchymal metastasis like deep lung, brain, bone is not the cause of death. The principal site of the metastasis is within the abdominal cavity, and people die of cancer, cachexia, obstruction, peritoneal disease. If there is a way we can control the peritoneal disease in the abdomen, patient has good DFS, patient is very fit, they can take multiple line of chemotherapy, PARP inhibitor or anti-angiogenic with a medical oncologist and can have an overall survival in excess of 5 years. So the whole concept is all ovary cancers come like this in India and abroad. 75% of them are in advanced stage 3C, which looks to be hopeless. Even if you do a fantastic surgery, peritonectomy and optimal cytoreduction, no cancer disease as is done in this. Majority of them recur if you end up giving IV chemo alone. There are 3 options available in ovarian cancer. Number 1, standard of care, good surgery and IV chemo. If you do this, best cytoreduction, 10-year survival, 5-year survival is only 10%. 90% of the women are dead with best chemo, with or without bevacizumab and a good surgery. This is option 1. Even in the new trial, which is a Scorpio trial, which was published last year, excellent surgery done and lot of beautiful chemo, 50% received bevacizumab, state-of-art treatment after surgery. Still, if you look at this particular area, good surgery, 75% optimal cytoreduction, IV chemo, even the bevacizumab maintenance, which is standard of care, still the survival was 15 months, pathetic 15 to 41 months, and PFS and OS, whether upfront surgery and chemo or interval cytoreduction after chemo with surgery, bevacizumab is pathetically less than 41 months, 15 months, everybody failed. Result not good enough. Option number 2, because intraperitoneal chemo can give high concentration rather than the IV, and you can control the disease. There are 7 randomized control trial. GOG 127 showed significant survival benefit, 100-month survival. After that, there were 7 randomized control trial. Meta-analysis proved that it is a level 1 evidence with significant OS survival. Unfortunately, not many institutions use because of the port problem. Even though ASCO told, even in the era of neoadjuvant intraperitoneal chemo should be practiced. Even when we have evidence for Indian setup from my group for 7 years follow-up of more than 200 patients with excellent survival of 62 months, published in EJC from India, we cannot use it because of the complications. So then the option 3 is good surgery, heat with chemo, intraperitoneal in the same setting, remove all the microscopic disease is removed. You do a fantastic surgery. Advantage is no adhesions, single shot, same time, surgery is over. Heat and chemo give cytotoxic penetration more than 1 to 2 centimeter, and then 2/3 of this patient don't recur. So is HIPEC hope or hype? I will take it by meta-analysis and everything. Is HIPEC effective? This particular trial, HINOVA trial, 2 randomized control trials in recurrent, 1 randomized control in interval, and 4 other randomized control trials. HINOVA trial showed that if you do surgery and give hyperthermia alone without chemo, that itself gives survival benefit. It's a beautiful randomized trial, brought in the concept of heat versus normothermic. Now we look at meta-analysis RCT, systematic meta-analysis. There are 7 meta-analysis with large amount of patients, more than 1,051 cases, 3 meta-analyses which were published in Chicago Consensus. All of them showed median overall survival, PFS were in favor. 13 studies, including 2 RCTs, meta-analysis published in EJSO, concluded addition of HIPEC to a good cytoreduction. 13 studies, 2 RCTs, 7 meta-analysis. You can look at the forest plot. The diamond, which is statistically significant, showed this. There are 2 randomized control trial of HIPEC in ovarian cancer. Number 1 real trial, very well conducted phase 3 multi-institutional trial, showed not only PFS, but significant overall survival is there in addition to surgery, bevacizumab, and standard of IV chemo if you do HIPEC. And the beautiful is, based on this, entire Netherlands and Europe, the insurance has approved this particular area. Does quality of life come down? People think HIPEC patient die, quality is poor. Beautifully addressed in RCT. Quality of life, no change whether you do HIPEC or not. Bowel resection, morbidity, mortality, no change. Look at this. CRS alone, CRS with HIPEC, bowel resection, stoma, same rate. Now there is another trial, Lim et al. Korean trial, never published, only abstract, withdrawn. Use 75 milligram cisplatin, not useful. 30 minutes they used, they included stage 4. This is the only trial which didn't show OS benefit, but as I told you, it's a poorly done trial, not published still. Abstract, 75 under dosage of cisplatin, very low dose, stage 4 also included. That's why it is not accepted. Now current Accural, ovary HIPEC trial 2 is going on. This has already occurred 2/3 of the patient. Even our center is one of this particular area, which is already showing a trend. Now, if you look back the platinum resistant and refractory, there is a prospective randomized phase 3 trial, second RCT, which showed survival benefit in both platinum sensitive, resistant, secondary cytoreduction patient. Now coming to morbidity, mortality. Morbidity, mortality is no difference in a center which has passed learning curve, published in EJSO by our group, also in RCT, which is available. There is one study from MSKCC, which used 30 minutes of HIPEC with carboplatin, did show survival benefit. The conclusion is not that HIPEC is not required. Carboplatin is not a good intraperitoneal chemo. Now people have moved down to cisplatin because of this. CHIP trial and 2 other trials have shown survival benefit significantly. This is the data from India, from HIPEC Registry of India, 2016 patients, 26 centers across the India. Look at the mortality, 3.6 only. We have published it, CRS alone versus HIPEC. HIPEC has significant survival benefit at 4 to 5 years, 40% if you had. Indian data, Indian patient, 2000 patient HIPEC Registry of India, which shows survival benefit in India. Rightfully, the guidelines, NCCN has included in interval cytoreduction, you should offer this at a very high level. Even in the era of PARP inhibitor, HIPEC makes platinum resistant sensitive and PARP inhibitor adds to the HIPEC. Look at the cost. 1 year bevacizumab cost, PARP inhibitor HIPEC, fraction of cost, significant survival benefit. And there are 7 meta-analyses, rightfully Chicago Consensus recently concluded that based on 7 meta-analysis, 2 RCT, all showing OS, PFS, now it's a very high level evidence. So in conclusion, I want to show upfront surgery, level 2 evidence, waiting RCT. Interval, yes, already RCT is there. Recurrence, 2 RCTs are there. So it's a very high level evidence. You can either do a surgery, give IV chemo, bevacizumab, fail within 1 year, platinum resistant, die in 3 years, do a HIPEC, good surgery, prevent abdominal recurrence. Failure happens at 3rd year, platinum sensitive, sequential chemo, bevacizumab, PARP inhibitors, patient can live 60 to 70 months. So it is your choice where you want to decide. And I rest my case. Thank you very much.
Thank you so much, sir. I now request our second debater, Satinder ma'am, to please go ahead with the debate. Over to you, ma'am. Ma'am, your mic is muted, ma'am.
Sorry, yeah. Can you hear me?
Yes, ma'am. And can I request you to make it full screen as well, ma'am?
So at the outset, I would like to thank the organizers for having me here. Dr. Somashekar has very beautifully and boldly shown us a ray of hope in HIPEC. But from the time this word was coined to now, with 20 years of evidence, what me and you can see on the screen is just hype. So this word has only hype in it and no hope. Somehow, HIPEC has become more of an obsession rather than just a passion for few of us. But a wise man proportions his belief to the evidence. And this is what the evidence has to say. There is no role for HIPEC in ovarian cancer. This is the recent commentary which has been published 1 month ago and which has received a lot of backlash from the HIPEC supporters in the social media. But what does it say? It just says the evidence. And we all are here to believe in evidence. And let's see what the evidence has to say. So let's see in all the settings. First of all, in the frontline management of ovarian cancer. Yes, there are multiple studies with many publications, and just look at the number of patients. Majority of these studies have patients around 50, and majority have not even reported the median PFS and median OS. Only RCT, which was published in the primary settings by Lim et al. In 2017, did not show any statistical superiority of the HIPEC arm. But yes, there is still hope. We are hoping that OV HIPEC 2, which has recently been started in January 2020, and the results are going to be published in 2026. The HIPEC supporters feel probably this trial will show them some hope. Now coming to interval debulking settings. Yes, the hope was seen. Hope has been seen by this OV HIPEC 1 trial, which sir has mentioned, and it did show an advantage in RFS as well as in overall survival. But what about the trial? It took 10 years for this trial to complete with only 245 patients. And it included patients which were initially inoperable. There was no stratification according to important prognosticators such as BRCA status, FIGO stage, response, or histological type. It was based on the surgeon's decision whether it is operable or not operable. There was a lot of imbalance of histologies, with 13 patients in surgery alone group with unfavorable histology like mucinous and clear cell. Randomization of subjects before completion of surgery, leading to bias in surgical radicality in favor of the HIPEC group. There was a non-transparent surgeon qualifications, and the effect of HIPEC was lowest in the centers that recruited almost half of the patients. And possibility, there is also an underreporting of morbidity and quality of life, the data which was shown, because this is in contrast to project 7 RCT in colorectal cancer, which was conducted at the same time, and it did not show any survival advantage, but was increased rate of 60 days serious adverse events and longer hospital stay. And also the findings of this trial are applicable only for small subset of patients who were unfit for primary surgery. So what did the editorial have to say about this trial? This randomized trial should not drive changes in practice yet, and primary cytoreductive surgery remains the preferred approach over neoadjuvant treatment, and administration of HIPEC at the time of interval cytoreductive surgery does not change that. Now coming to the relapse settings. In the relapse settings, there was one trial, yes, this RCT by Spilatos et al., which had a lot of problems in the trial design and has that's why never been accepted, though it came in 2015, but somehow it has never been accepted because of the fallacies in the trial design. And the recent phase 2 study by MSK Ovary group did not show any survival benefit. So there is only retrospective data which shows the advantage. And though we have a lot of data from Indian thing, but there is no RCT. And this review, which was published by Shiva et al. In 2015, with 22 publications and 1450 patients, actually said that HIPEC cannot be considered a standard treatment and should not be offered outside of clinical trials. And let's see what the guidelines have to say. Yes, the AGO Australian and Switzerland group says that HIPEC remains experimental. Its use is not recommended and should be rejected outside of prospective controlled trials. The ESMO-ESCO consensus guidelines, which were published in 2019, say that HIPEC is not the standard of care as first-line treatment and has not been proven to be of benefit in the secondary settings also. The recently published ASCO Stratified Guidelines 2021, which do not mention HIPEC even in settings with enhanced resources. So only the NCCN says that it can be considered in case of interval debulking settings and not in primary and relapse settings. Oh, this baby is very upset because his toy is not working. Anyways, let's look at the morbidity data also. So this systemic review and meta-analysis shows the rates of complication ranging from 0 to 65%. The grade 3 and grade 4 morbidity reported are to the tune of 31%, which is quite high. And yes, the cost. When we compare to a cytoreductive surgery, the cost of HIPEC is exorbitant. There is a relevant economic deficit for the hospitals offering this treatment option to their patients. And what about the role of HIPEC in the era of PARP and BEV? PARP has been a game changer. The survival, if you're talking about the survival data, the survival has actually improved by, this is the only drug which has shown improvement in survival. So I rest my case stating absence of substantial phase 3 RCT data demonstrating the benefit of HIPEC. There is positive selection bias in all HIPEC trials. There is heterogeneity in chemotherapy drugs used, limited number of patients in majority of the trials, a lot of perioperative morbidity, high cost. Will the survival benefit be seen in settings of PARP inhibitors and bevacizumab maintenance? So less pain, more gain, or more pain and no gain. So you cannot defeat evidence by opinion. You can only defeat evidence with stronger evidence. Thank you.
Thank you, Dr. Satinder. So this debate got heated and it's got tie, and we have a third umpire with us, and that is, and he is Dr. Hemant. He's the Director, Urology, Gynecology, Oncology, Surgery, and Surgical Oncology Department, Nanavati Max Hospital, Bombay. And he will take a decision or expert comment on this debate.
No rebuttal for a minute?
Sir, yes, sir. So can we give 1 minute rebuttal to the debaters?
Yeah.
Yeah, actually, actually, I'm very surprised. Satinder, I thought is, more academic, and she's going to analyze. The last slide was apt for her. No evidence shown. I'm very surprised. Number one, she says that it took 10 years for to OV HIPEC trial. Common sense, 5 years you have to wait for overall survival to report. Any trial is not like medical oncology where patients die in 6 months, 3 months survival with 1 crore medicine, clap and say. Any trial in surgery, patient leaves. So you need 5 year follow-up from the last trial. So obviously 5 plus 5, 10 year is the trial. Number one. If you have not done that, people would say, oh, you didn't follow 10 year. Number two, morbidity, RCT reported, RENAP trial reported. Indian HIPEC registry 2000 patient, 3.4% in India. So morbidity all in favor of HIPEC. Second, NEMJ editorial, totally wrong. Please go back to that particular slide. That slide, NEMJ editorial you showed was not on HIPEC. It was telling, please do upfront cytoreduction, not neoadjuvant chemo interval. Please read that line. Go back and see that. That slide concluded in editorial. It is upfront surgery and not neoadjuvant, which as most of the people do. Third part, Braca was not there. 15 years back, where is Braca? Telling that after 10 years, oh, there is no Abimaciclib in 10-year trial. If you are not gone, where is that? You think 10-year Braca and Olaparib was there? So that you cannot tell in a trial on that day to do today. Fourth part, Prodigy trial. Please don't compare orange with apples. Prodigy trial is for colon cancer. Colon cancer is a stage 4 cancer with peritoneal mats. Palliative intent. Ovary peritoneal mats is stage 3C curative intent. Colon has anastomosis with HIPEC. Ovary is a surface disease. Please don't compare Prodigy with this. You can't say that I used a trial in CS cervix, so breast cancer, you can't use the same drug. Wrong. Second, you showed 10 types, 12 cases. Where are you? 11 trials of 1,000 cases is published now. I'll send all my slide to you. You showed the list, that is 1942. Now we are in 2020. There are 1,000 cases, 27 studies and 4 meta-analysis, 1,000 cases. Morbidity. None of the trial has shown morbidity superior to this. So I rest my case based on the evidence, opinions of, if we don't do it, just because we don't do it, it doesn't exist is wrong. We should do, publish, analyze the data, and then we should speak, which is fully evidence-based in my slide. Thank you.
Over to ma'am for her rebuttal.
I think I've already shown all my evidence, and it is from the RCTs. Definitely it is not my data, but yes, if it is the personal data, then it should be in the form of RCTs. And that is what I have to say. We can publish, we all know that retrospective data have an inherent bias in them. And whatever I have said is all based on randomized control trials. And I think Dr. Tangaonkar is the best to make a final statement on that.
Well, good evening,
please.
Yeah, good evening, everybody. I think both the speakers have very passionately put forth their views. And I know Somashekar is always extremely passionate about HIPEC. Well, if you look at the evidence really and draw valid conclusions, I think we are jumping the gun. I think we should wait for more evidence to come. Today, the weight of evidence does not point towards incorporating HIPEC as a standard of care in treatment of ovarian cancer, whether it is an interval surgery or recurrent. Primary, of course, there is no question of using HIPEC, but even in interval, where it is the randomized trial has shown some benefit, even in those, that trial has been so poorly conducted that I don't think we can really take that very seriously. In recurrent, of course, there is no evidence. Even the meta-analysis shows that there is no evidence of benefit. So I think, I'm not saying that everybody who treats ovarian cancer knows that we want something new to improve the survivals. Yes, but we try so many different methods and hope something will come. So I'm hopeful that HIPEC will be useful, but we'll need to define the subset of patients in which it will be useful. So right now, I think it's a hype. I think even those who are passionate about HIPEC should tone down their enthusiasm and look for really valid evidence if they want to do some service to science. Thank you.
Thank you, Dr. Tangaonkar. So still there is a hype, means concluding remarks, a hype, but we have hope for a coming time, and sure we can win the race. So thank you, our dear speakers and Dr. Tangaonkar. Now we move on the next session of this, next part of this session, and that is some debate, is a panel discussion, and we have a moderator, Dr. Amita Maheshwari. She is a professor and head in Division of Gynecology Oncology Department, Tata Memorial Cancer Hospital, Mumbai, and she will moderate the session. And we have a panelist and Dr. Sampada Desai, consultant gynecology cancer surgeon, robotic surgeon, Hinduja Hospital, Mumbai. Dr. Ankit Nehra, consultant medical oncologist, SCG Hospital, Jaipur. Dr. Avinash Talare, consultant Department of Medical Oncology, Asian Institute of Mumbai. Dr. Srinath Bhardwaj, consultant medical oncology, Apollo Hospital, Hyderabad. And Dr. Saurabh Kumar Mishra, consultant medical oncology, Apollo Hospital, Bhubaneswar. So, Dr. Amita, now your time starts.
Yeah, thank you so much. So can I share my screen? And thank you very much for the invitation. And welcome everyone to this panel discussion on a very interesting and controversial topic on single versus double agent maintenance therapy in ovarian cancer. So can I just share my slides? Okay.
Sure, ma'am.
Yeah. So I hope all panelists are there. Okay. If you can.
All panelists are there except for Dr. Sandeep.
Okay, thanks. So in the interest of time, we will restrict this discussion to maintenance therapy in frontline ovarian cancer. So to put things in perspective, with over 45,000 new cases per year, so ovarian cancer is the third most common cancer in Indian women. And with conventional chemotherapy, the long-term survival outcomes are dismal. However, in recent times, results of 4 randomized trials using PARP inhibitor-based maintenance therapy has really revolutionized, and I think unbelievable PFS outcomes have been seen. So all these 4 trials, although they are somewhat different in their design and population included in this trial, but one important point to note that except PAOLO trial, all trials have control arm placebo, with active arm being PARP inhibitors, while in PAOLO trial, the control arm as well as experimental arm has bevacizumab maintenance therapy. In both the arms it was there. So as I said, results are quite encouraging, but as a clinician, I think the biggest challenge is how to implement results of these trials in our clinical practice, and that's what I think we are going to learn from our panelists today. So just to start with a case, a 57-year-old fit lady from upper socioeconomic class, diagnosed with advanced ovarian cancer, and after joint clinic discussion, she was found to be suitable for primary debulking surgery without HIPEC as our protocol, and optimal cytoreduction to no gross residual disease was achieved. The histopathology showed high-grade papillary serous carcinoma. So she was a case of stage 3C high-grade serous ovarian cancer. Meanwhile, we also got her germline Braca testing done, and she was found to be positive for pathogenic mutation in BRCA1 gene. So my question to all panelists is, what adjuvant treatment at this point would you offer to this patient? I have put a couple of options. You may not agree, and you may have something different to offer to her. So may I start with Ankit?
Yes, ma'am. So I would like to give paclitaxel carboplatin 6 cycles. Along after that, maintenance olaparib. So
just quickly, Avinash.
Avinash, sir, you'll have to unmute your mic, sir.
Yes. Yeah, I would go with the solo one protocol as a paclitaxel.
Okay, and Dr. Srinath, Saurav.
Madam, solo. I would also go with the solo one protocol.
And Sampada. So I never knew we will reach to consensus so quickly. I don't know if you truly believe or really hungry. Okay. So anyway, let me then act as a devil's advocate and ask you why not? What's wrong with PAOLO 1 trial, which is, concurrent and maintenance bevacizumab along with olaparib? Why not PAOLO 1?
Because, madam, Avinash here, I would say, because bevacizumab in adjuvant setting has failed to make a difference. We know that pretty well. That is right. Reasons, and this patient has undergone optimal debulking.
So let me put it this way: any subset of patients where you will think a double maintenance agent instead of single. Do you think any patient population is a candidate for doublet?
In adjuvant, madam, you are asking?
No, I am talking about maintenance. We'll stick to the topic of the panel.
Okay.
Yes, we frontline maintenance therapy. Okay, Sampada, you have different thoughts?
No, I agree with solo one.
Okay. So that's the quickest ever consensus we have reached. Anyway, so let me just take you through. Sorry.
Madam, Saurav here. So basically, madam, if this patient had any of the high risk features, I think this is a very optimally cytoreduced patient. He didn't have any ascites, no pleural effusion. So if these were the things present, probably I would be tempted to go for something like a Bev plus olaparib combination, and in those subset. Otherwise, solo is something which we would prefer.
Right. So I think evidence doesn't suggest that we should be adding a combination if it is suboptimally. If you see solo 1 design, they included patients who had incomplete surgery, even biopsy, and there wasn't any difference. In fact, the whether it was IDS or PDS or it was optimal or suboptimal, it did not really wasn't a prognostic factor in solo one trial. So I think on that ground, we are not very sure whether we will add BEV there. But let's just quickly in the, sorry.
Yes, ma'am, may I add something, ma'am? So, so for your first question, ma'am, for solo one trial, so if the patient is BRCA positive, I would like to give olaparib only because of three things. So 3-year PFS, though we cannot compare both the trials, but 3-year PFS was around 60% in solo and it was around 70% in Paula. Second of, and then in latest update, ASCO 2020 update is also there for solo, which has shown a DFS of 56 months, and we don't have any long-term follow-up of Paula till now. And then third, that the side effects are very high with bevacizumab. So with these 3 point BRCA positive patients, I would like to give solo only. Right. And those who are, yes.
Again, my question is, you think BRCA positive, you say solo, but you know, any subset based on molecular marker would you consider for combination?
BRCA with HRD positive with the HRD positive patients, or BRCA negative with HRD positive patients, I would like to give bevacizumab also in the maintenance, because it wasn't included in solo one trial at all.
Right. So that's right. I think that's the subset which is not there in solo one. Anyway, just I'll quickly take audience through these two important trials, Paolo 1 and solo 1. So essentially same design, advanced epithelial serous or high-grade endometrioid carcinoma. The one difference was here maintenance BEV was given in Paolo 1 in both arms, because it's an European trial and the centers started, they actually have BEV as a routine standard of care, while in solo 1 that was not the case. And also in Paolo 1, actually they included regardless of BRCA mutation status, and subsequently BRCA mutant or non-mutant were included. In fact, and stratification was based on a BRCA mutation. And of course, other things are same between these two trials. And what was the basis actually of adding BEV, adding olaparib to BEV? Actually, the hypothesis is that anti-angiogenic agents may cause hypoxia, which in turn induces HRD in tumor and potentially increases tumor sensitivity to olaparib. So that was the whole basis of this trial, although I think trial results really do not support this hypothesis. So what Ankit just mentioned, if you see actually solo 1, it was only in patients who have either somatic or tumor, somatic or genetic germline, BRCA mutation. So that's the only, very homogeneous population. So HRD or no HRD groups were not included. But when we compare these two, subgroup of Paolo 1, which had either somatic or germline BRCA mutation, the exactly same hazard can be seen, and similar benefit is obtained in patients who just received olaparib without BEV. Of course, HRD is one population we really don't know, but if we compare, if we look at niraparib trial, their patients with HRD actually got benefit to the tune what we see here with addition of Paula. And of course, patients who had no HRD, they did not benefit from addition of PARP inhibitor. So that's, I think, very clear we are getting. Of course, this is one group which we are not very clear. Now, let me come to you, Ankit. In practice, are you able to get HRD?
Yes, ma'am. We are doing HRR panel by NGS. At least it is including ATM, PALB2, RAD, 51C, and A.
No, so we are talking about tissue homologous recombinant thing. Are we able to study genomic instability in these patients? What trials used is my choice test on tissue, which I think few companies are offering in India, but is still not standardized. So I really think that this population is really may not be at this point very relevant to us. Of course, once we have HRD testing standardized in the country, we may. But currently, we have to send it to my choice to have a proper results. Okay, so based on, interestingly, although none of our panelists agreed, but based on results of Paula 1 trial, in fact, both American and European patients can avail, because both FDA have approved this combination in patients who are either BRCA or BRCA mutant or have genomic instability. And of course, you have to be platinum sensitive. Response to first-line platinum therapy is required. But as I said, substantial proportion of tumors may have HRD, which currently is very difficult to get in our patients because we do not have this facility widely available. At this point, any panelists want to make any comments? Okay, so I'll just quickly, how cross-trial analysis can be fallacious, just to show that Vargot and group, they presented this trial. They compared Paula 1 patients who had BRCA mutation were to Solo 1, and they did weighted mean analysis. And what they showed is that PFS in patients, when we do indirect comparison, olaparib monotherapy versus BEV, definitely olaparib was superior to BEV. Of course, these groups were not there in individual trial. This is cross-trial comparison, and one has to be very, very careful to make any conclusion from these cross-trial comparison. But when they also compare olaparib plus BEV versus olaparib monotherapy, there was some trend in improvement with combination. Again, although it's crossing unity, but there was some trend. But as I said, currently we really, based on this, we cannot extrapolate the result because it's absolutely cross-trial comparison. And as Ankit rightly mentioned, you have to remember toxicity, and additional toxicity in Paolo 1 is hypertension. So it's just not about the cost. Of course, additional cost, that's one concern, but toxicity, what patients get with the use of additional bevacizumab. So that's another point. And also, I think some of you may think, these patients eventually going to recur at some point in time, and I don't know whether we want to keep BEV in reserve at that time. So what are your thoughts on this point? Saurabh?
So basically, whether to use, I just didn't get your question actually.
So my question is, would you, given a choice to use BEV along with olaparib upfront versus keeping it in reserve for future recurrence, when, eventually tumors do become platinum resistant. So when do you use BEV in your practice?
So as I said, madam, BEV I usually prefer in those patients like in the GOG 218 or ICON 7, in those subset of patients in which BEV had actually shown benefit. That was in the suboptimally cytoreduced patients with stage 4 disease, lot of effusion, lot of ascites. That is the subset where I prefer BEV. Otherwise, routinely not. That's what I do, madam.
And if that patient is now a candidate for PARP inhibitor, would you consider BEV plus PARP or PARP alone?
So comparing both the things, madam, whether only BEV plus PARP inhibitor or only PARP inhibitor, I believe as of now, whatever evidence and comfort, I would rather prefer only a PARP inhibitor because of the toxicities and unclear benefits of bevacizumab. That's what I would say.
Right. Is Dr. Srinath there? I can't see him if he's there and he wants to make any comment.
Ma'am, I profoundly believe that there is no evidence as on today in BRCA1 and HRD positive tumors to combine both olaparib and bevacizumab. I'm very clear if my patient is BRCA1 or HRD positive. I'm unfortunately using the Indian HRD panel, not the My Choice, because of the cost. So
I think Indian we have not yet standardized. Yes,
validated,
but I think
yeah. So, but in those patients also, I'm currently using only PARP inhibitor. I'm not combining both, and I'm not really in belief that BEV had anything to do with the benefit in Paula trial.
Right. I think most of us agree. I mean, all of us rather agree on this point. Sampada, I have a question for you. If you all see all these trial designs, so patients, whether they have suboptimal, optimal surgery, neoadjuvant or upfront surgery, all kinds of patients and response is the same. So do you think as a surgeon, we are somewhat threatened and our importance is going down? And, so we also better start, learn right time to learn how to give these drugs and manage their toxicity. What are your thoughts? You think the importance of surgeon and surgery is going down with the advent of all these things?
None of the optimal cytoreductions and all the efforts are most important thing that plays an important role. If we don't optimally cytoreduce them, all these things will not work. So
that's truly coming from a surgeon's heart, although these trials disappointingly showed that patients who had either suboptimal surgery or optimal, they also did benefit as long as they were sensitive to platinum therapy. There was a response to platinum therapy.
So, madam, I want to make a comment. Yes. Dr. Avinash here. So, optimal debulking, only surgeon can do that, and not just a surgeon, a good skilled surgeon can do that. So, unless you put in your golden hands, we cannot offer them prolonged PFS or cure. So I think at least in ovary and most of the solid tumors, surgeons are indispensable.
Right. Thank you so much.
Other thing, madam, also, if at all we want to say whether the surgeon's role has reduced or anything, we need to do an analysis between what happened to those patients who were optimally cytoreduced and then got PARP inhibitors and those who were not optimally cytoreduced and got PARP inhibitors.
So in these trials, actually, it was shown that cytoreducibility or the R status did not affect the survival. Okay. So one thought is maybe targeted therapies are deeper than surgical knives. Of course, we still have to wait and see more data on it. So I think we are just coming to the end of this, and the future is now we are debating on doublet. Of course, we don't agree for the current doublet, but the future may be triple targeting. So the aim is to target cancer cells from all sides, and there are many trials ongoing. Having anti-angiogenesis, DNA damage molecules as well as immune checkpoint inhibitors, and a number of trials are ongoing. Some actually have shown not to be very useful, but overall future is very exciting for ovarian cancer as far as targeted therapies are concerned. But my only concern is that as an oncologist, we may say हमने cancer cells को चारों तरफ से घेर लिया है, but cancer cells may say that चलो गरबा करते हैं फिर. So with this, I think I will end. And any quick comment or remark from any of the panelists before we wind up?
I think regarding this role of surgeons, ma'am, I just want to make a comment. I think none of the targeted therapies have really proven OS benefit, but R0 resection still has that OS benefit. So I think.
I was just kidding. That was just a thought. Of course, just to say that we are.
The support of the surgeons. That's all.
Thank you so much. We wanted that support. Okay.
Thank you.
Thank you, Dr. Amita, and thank you all the panelist team. And we are almost end of this session, and this is remain the interesting session because we have a debate on HIPEC therapy, the hope and hype, and later on Dr. Amita has solved the puzzles, how we use the maintenance therapy. Either we have used single or double or discuss the all trial and Paloma trial as a comparative data and solve the puzzles with the help of the all eminent panelists. So now we end this session, and I hand over the mic to organizer for start the next session. Thank you very much.
Thank you so much.
Thank you very much.
Thank you so much, ma'am. Thank you to all the panelists. We'll move on to the next session. This session is on prostate cancer, and it gives me great pleasure to introduce our session director, Dr. Abhishek Parikh, Senior Consultant, Department of Surgical Oncology at HCG Hospitals, Jaipur. With that, I'll hand over the mic to our session director, and I request you to please start the session and introduce our chairperson. Over to you, sir.
Good evening, everyone.
First of all, I want to thank Dr. Hemant Malhotra sir, Dr. Lalit Mohan Sharma sir, and entire team for this wonderful academic feast. With this, I would like to introduce my chairpersons. So the Dr. Sumit Goyal, he is working as associate professor in the Department of Radiation Oncology, Shri Ram Cancer Center, Mahatma Gandhi Medical College, Jaipur. Dr. Shikha Dhal, she is an associate professor in Department of Radiation Oncology, Shri Ram Cancer Center, Jaipur. Dr. Sachin Jain, he's a medical hemato-oncologist, associate professor AIMS, and is a senior consultant in working in Udaipur. So over to chairperson, please.
So can I request Dr. Shikhar to introduce our first speaker? Over to you, ma'am. Shikhar, ma'am, you'll have to unmute your mic.
Yeah, good evening, everyone. Welcome you all to the next session on CA prostate. And to present the talk is we have the speaker, Dr. Samant Gupta, who is Senior Consultant Medical Oncology and BMT HOD, Sarvodaya Cancer Institute. And his topic is on new combination of old drugs, the PEACE-1 and the STAMPEDE study. So welcome, Dr. Sumant Gupta.
Thank you, ma'am. Thank you for the kind introduction. And first of all, I'd like to thank the organizers for giving me this opportunity. Is my slides visible?
Yes, sir.
Thank you. So prostate cancer has always been an interesting topic, and I think the most difficult disease to treat because the sequencing and all has always been a challenge to all the medical oncologists. And the second part of the discussion has always been that the patients are usually in a transit between the urologist and the oncologist. So some part of the therapy the patient usually have with his urologist, who is the primary physician, and the patient then comes back to the medical oncologist either as a metastatic, hormone sensitive, or a CRPC to us. So this topic which has been given to me is a new combination of old drugs, the PEACE-1 and the old STAMPEDE study, and I'll try to complete it in the 10 minutes time allocated to me. So STAMPEDE study, I'm sorry for those hazy slides. STAMPEDE study, we all knew, was the old trial where we had the first time where a triplet or doublet drugs were used, where standard of choice chemotherapy was used along with the ADT. And it showed that among men with locally advanced or metastatic prostate cancer, ADT plus abiraterone and prednisolone was associated with significantly higher rates of overall and failure-free survival than ADT alone. This is the PEACE-1 study, which has been recently discussed in the ESCO GS symposium, and this shows the overall survival with abiraterone with or without local radiotherapy with SOCs in de novo metastatic castrate-sensitive prostate cancer. So this is bringing the role of a triplet or a chemotherapy plus abiraterone to a metastatic CSPC variant of the prostate cancer. So coming to the background of the PEACE-1 study, the treatment of metastatic CSPC has evolved in the recent times from ADT alone. So all of us have used ADT alone to ADT in combination with chemotherapy, most commonly the docetaxel, and plus minus radiotherapy. This phase 3 study conducted to evaluate the addition of abiraterone acetate, or Zytiga, the most commonly used drug, to this combination. Previous analysis reported significant PFS in addition of this combination. This was the STAMPEDE, which we were discussing, which came out in 2017. And current analysis reported the OS of this trial. So this is the PEACE-1 study design. It was a multi-centric, randomized, open-label phase 3 trial. These are the 4 major discussions: abiraterone plus minus radiotherapy plus standard of choice chemotherapy, which is again most commonly docetaxel, abiraterone plus the chemotherapy, radiotherapy and chemotherapy, and the chemotherapy alone. The co-primary endpoints were RPFS and OS into a 2:2 fractional designs, and the other secondary endpoints were also there as usual. The basic analysis which were done was now in between two arms, which was the chemotherapy arm and the chemotherapy plus abiraterone arms. So if we see the characteristics and we go through the characteristics, both the arms were quite well balanced, and the number of patients was also around 350 in both the arms. So this is the first graph which shows the radiological progression-free in the ADT plus docetaxel arm. So if you see the yellow line, which is the chemotherapy plus Abiraterone, and the gray line, which is the chemotherapy alone. So for the radiographic progression-free survival, the yellow arm is quite a interesting winner, and we clearly see the benefits of adding Abiraterone to this particular arm. This is again a subgroup analysis where they had tried to compare whether high volume versus low volume there was a difference, and what they found out that the p-value was much more significant and important in the high volume disease, and this was also clearly seen with the separation of graphs which we can see in this photograph. Coming to the overall population analysis, the OS with Abiraterone plus ADT in the docetaxel population plus minus radiation, there was a clear separation of graphs at 5 years in the SOC plus Abiraterone arm. If you compare the subgroups, the diamonds are all on the left side. So whether the radiotherapy was given or not given, whether the type of castrations or the metastatic burden, all were on the left side, and high volume disease was a better predictor of this particular subgroup. So these are the other subgroup analysis which was done, the OS benefits and others. So again, in the OS also, the high volume disease was clearly the winner, and in low volume disease, it was quite a mixed bag response. This particular shows the treatments which were done beyond progression, and all the major drugs which have been used in these settings. So it is more, if we discuss this, piece one is more of a real world setting clinical trial where most of the usage has been what we have all been using as clinicians in our day-to-day practice. Coming to the toxicities, the major grade 3 to 4, 5 toxicities, neutropenias was definitely there in around 10%, febrile neutropenia in 5%. Hypertension was quite commonly seen in the addition arm, and rest of the toxicities were quite common. So hypertension was something which was more in the combination subgroup. So coming to the conclusions of the piece 1 study, addition of Abiraterone to the ADT docetaxel was associated with a significant improvement in the efficacy with de novo patients. There was a 2.5-year improvement in the median RPFS and 25% reduction in the risk of death despite high use of subsequent life-prolonging therapies in the control group. Survival benefit was observed in men with high volume metastatic disease. Toxicities were more or less expected, and investigators concluded the data are practice changing and at least men with high volume de novo. So the high volume de novo is the most important catchword which should be offered the ADT plus docetaxel plus Abiraterone triplets. So if we come to the discussion which I have been assigned to, the new combination of old drugs. So most of the analysis which have come after the GU symposium, the piece 1 and Stampede studies found that addition of Abiraterone acetate plus prednisolone to the standard therapy definitely lengthened the compared. The author Karim Fizazi from the French group clearly has mentioned in all the major interviews that piece 1 is a first trial to establish that the triplet treatment should be offered to these men, especially those with more aggressive multiple metastatic sites, and more additional side effects with the triplet combinations were mostly mild. So if we remember the slides, hypertension was the most common side effect in the triplet arm. So Stampede focused on non-metastatic, no spread visible on conventional state, but high-risk prostate cancer, approximately 20% of localized prostate cancers at high risk at the diagnosis, but account for majority of relapses subsequently. And the trial found that at 6 years, men who had received standard treatment plus AAP for 2 years had an improvement in survival. So these two trials, the old Stampede trial, which all of us had used as a benchmark and most of us has taken as a practice-changing guidelines, and the new piece 1 again shows that addition of the triplet to the standard treatments of prostate cancer definitely has been showing survival advantages. Thank you for your patient listening, and I know in the evening times it is very difficult to keep everyone waiting.
Thank you so much, sir. I now request our chairperson, Dr. Sumit Goyal, to please introduce our moderator and our panelists.
Good evening, everyone. And thank you, organizer, for giving the opportunity. Now, the next speaker is the Dr. M. Vamsi Krishna, Director and Head of Medical Oncology and Hematology Institute of Oncology at Hyderabad. We'll have a panel discussion about the metastatic castrate. And the panelists are our Dr. Sanjay Desai, Professor and Head of the Department in the Indore, Sir Arvindo Medical College, and Dr. Advanta Gore, Associate Director Medical Oncology, Nanavati Max Hospital, Mumbai, Dr. Asutosh Daga, Assistant Professor in Chennai, Adyar, Dr. Shruti, Medical Oncology at SCG Nasik, Dr. Devesh Goyal, Senior Consultant Medical Oncology, Fortis Jaipur, and Dr. Avinash, Consultant and Department of Medical Oncology in Mumbai Asian Cancer Institute. Now, welcome to the panel discussion.
Good evening, everyone. This is Dr. Vamshi here. I hope I am audible.
Yes, sir, you're audible, sir.
Thank you very much.
Vamshi, we want to see your lovely face also. Please put your video on.
Sir, I'm actually traveling and I am in a car, so I don't
Okay,
think my
okay, no
lovely
issues.
features are visible.
Okay, okay, no issues. Take care.
Yeah, apologies for that. Actually, I missed my time mismanagement and I was supposed to be at home, but unfortunately, I'm out on the road. I'm in a very nice position today because I was told that I have to start speaking from 8:55 and I'm actually 5 minutes early. So that's something that I think has rarely ever happened. So I must congratulate the organizers for that. Right. So my topic is going to be management of metastatic CRPC. Next slide, please. So this is what we have been taught from donkey's years. This is how our natural history of the prostate goes. You have loco-regional, biochemical failure, then you get metastatic sensitive, and finally metastatic refractory. Next slide, please. Now this thing is what has been drilled to us. So let me just start off with Dr. Shruti. How do you actually diagnose metastatic CRPC? Would you go with the PSA only? Next slide. Would you do a PSA with PET-CT to diagnose progression, or do you use a combination of both? Dr. Shruti?
Yes, sir. So I would actually pick it up either by symptoms or a rising PSA, and then I would follow it up with a PSMA PET-CT to confirm. I mean, the sites of disease and also the tumor burden. Yeah.
Okay. Dr. Avinash, do you agree with this? Or would you just go with a PSA? You know, we have this debate that we keep doing PSAs every month and then you'll find some value going up. Would you call that a metastatic CRPC or would you like imaging as well for that?
So I would agree with, so I would do PSA doubling along with an imaging, normal PET also, and a combination of PSA and imaging demonstrating an increased tumor burden with symptoms.
Okay. I think that's the point which I was trying to bring about, that just PSA alone is okay when you're talking of a metastatic HSPC, when you're talking of a non-metastatic CRPC, but it's always good to get an imaging done to confirm your CRPC. Again, I'm not saying that we should follow up a CRPC with a routine PSMA PET. That's not what I'm saying, but it is good to have this combination along with the clinical features before you can diagnose a metastatic CRPC. Dr. Advait, how often do you continue doing the serum testosterone? Next slide, please.
So generally, whenever that we are suspecting a CRPC, that's the only time where I would do it. I would not do it later on.
Perfect. I think that's again a point I wanted to make, was that there's no point in doing routinely. You are on proper ADT, probably that's enough. But just to confirm before calling it a metastatic CRPC, it's good to do the testosterone values. Next slide. Right. Dr. Devesh, what's your thought on this? Would you continue the same ADT? Would you do a different ADT? What's your thoughts on this?
So actually, if we have declared this metastatic CRPC, so I think I will switch over to androgen deprivation therapy. No, I will switch over to another drug, sir. In this, if the patient is the less symptomatic or symptomatic, so go on the abiraterone or enzalutamide versus the docetaxel.
Yeah, sorry. So the other thing which sir has, Dr. Lalit has asked a question, do you do intermittent or continuous? I mean, is that even a question? Would you do continuous? I mean, what's your thought on that?
Yeah, I think if patient are on ADT, then I will continue this.
Okay. Dr. Advait, any thoughts on intermittent ADT? As far as I'm aware, in the CRPC setting, only continuous ADT is what is needed.
I agree with you, Vamshi. In the CRPC, there is no role for giving intermittent ADT. It is only in
Absolutely.
the CSPT setting that there was some data earlier. But
Perfect.
even in that situation now, it is more of a continuous ADT because of the monitoring, which is very stringent, which is required.
Okay. Dr. Sanjay Desai, sir, what's your thought on this ADT versus orchidectomy? Would you prefer a GnRH analog and antagonist, or a simple orchidectomy is good enough?
Sir, basically, it will depend on the pocket of the patient.
Okay.
If the patient is ready to spend money every 3 months, the amount, then I am happy with medical orchidectomy.
Okay.
Otherwise, surgical orchidectomy would be the first option.
Very good. Next slide. Now, interesting thing, oral relugolix. Now, it's not available in India, but it was interesting for me to note that oral relugolix has actually not been tried in this setting. So again, the issue of an injection, somebody wants an oral. We still don't know if that can be used in a CRPC setting. Next slide. So this is what the ESMO guidelines. Now, this is 2020 guidelines. And what is striking is, just look at the number of drugs you have in the hormone-naive, castration-resistant first line, and in the high risk. Almost all the drugs that we were using in the castrate-resistant are already there in the first line. So next slide. Dr. Shruti, what do you think the paradigm, next slide, the paradigm that we used to actually go by? Now, in that situation, in practice, by the time a patient becomes a CRPC, how many patients of yours are actually given only ADT till then? How many would have received one of these newer agents or docetaxel?
So I would say around 60%, 50 to 60% would have received
50 to 60%.
Yeah, would have received
Advait?
chemohormonal therapy.
Advait, Bombay is full of oncologists, so would that number be higher for you as 80-90%?
So, Vamshi, it depends on where the referral is coming from. If there is a urologist who has sent it to us, then most of the times this patient have received ADT only and have not received anything in addition to ADT. That is what we commonly see in our referral patterns. But if the patient is with a medical oncologist or a surgical oncologist, naturally the referral is early, where almost I would say in my practice, 50% patients are on ADT plus another therapy instead of ADT alone.
Avinash, do you agree with this?
Yes, I agree. I completely agree with Dr. Advait.
Okay.
Yes.
Okay, I think you guys are in a good place. In my city, at least, most of the urologists give abiraterone and enzalutamide by themselves. So if you're in a place where they're not doing it, I think it's good for you. Next slide. Again, the reason I'm asking is now, how often do we actually see a metastatic CRPC naive to all these agents? So Dr. Shruti says it's around 50%. Dr. Advait says 50 to 60%. Dr. Divesh, what would be in your practice? How often do we see metastatic? Yeah.
Sir, again, 60 to 70%.
60 to 70% naive. So I think that's a rather remarkable number. To be in my practice, it would be only 20%, I would say, who has not received Abi or Enza or docetaxel. So that's quite a heartening number. So there's still a lot of things to discuss in the CRPC setting for us. Next slide. Right. So why I'm asking this again is, does the old sequence that first, as soon as they become CRPC, you give docetaxel, you give abiraterone, give enzalutamide in various combinations, does that sequence hold true today? Next slide. So let me come to some scenarios. Dr. Shruti, the first scenario is for you and others can also chip in. Patient in MHSPC was given docetaxel and then was only on ADT and now has progressed. What would be your plan in that case?
So I would want to know how many months or years back was the patient given docetaxel. So time to progression.
That's the question. How would that change your practice?
So I would, if the patient is very fit, I would want to re-challenge if the DFS is or time to progression is more than 2 years. So I would want to give docetaxel again and then follow it up with Abira or Enza. If that duration is less than 2 years, then I would want to not give dosi. If the tumor burden is very high, I would want to give cabazitaxel. If not, then I would want to give Abira or Enza.
All right. Okay. So your preference to Cabazi over Enza and Abira is based on the card study?
Correct.
Okay. Dr. Advait, do you agree with this? 2 years is it's a bit of an arbitrary number which Dr. Shruti is quoting to me, I feel. Dr. Advait, what's your
because
thoughts on
sir, only on ADT patient would be fine for around, I would say, 14 to 16 months. Bone only disease 22 months. So that's why you
2
actually
years?
have to, yeah.
Okay, there's no real trial on this. That's the reason I was asking. Dr. Advait, what's your...
Yeah, so Vamshi, it also depends on how symptomatic is the patient and how rapidly do you want a response. What is the burden of disease that the patient has now on progression to CRPC?
Okay.
I think it is all these factors and the patient performance status that one would take into consideration, along with the liver, the cardiac, and the renal profile, just to manage the toxicity. I look at generally a time period of 1 year. If patient in HSPC has received docetaxel a year back and now again is quite symptomatic for the disease and fit for chemo, if he is beyond 1 year, I would re-challenge the patient with docetaxel. Other options for abiraterone, enzalutamide are there, but in the sequencing, I generally prefer using enzalutamide, sandwich another chemo in between, then go for abiraterone.
Okay, very good. Interesting thoughts. Avinash, docetaxel re-challenge, when would you do it? Just a quick question. We are running a bit out of time. Yeah. Quick answer.
So quick answer again, I would re-challenge it after like 2 years.
2 years. So 2 years from Dr. Shruti and Dr. Avinash, 1 year from Advait. Dr. Divesh, re-challenge after what time?
Divesh, you're on mute. You're on mute.
Almost 1 year. I agree with Dr. Advait.
1 year. Okay. So we have divided camp. Has Dr. Ashutosh joined us yet? I think he is on an emergency, so could not join. Okay, fine. I think he has not yet joined. Next slide. So Advait, you can take the scenario 2. Now, patient was given abiraterone in the first line, is a metastatic HSPC, and is on abiraterone. Now, he has taken abiraterone for 2 years. He's on abiraterone and he has progressed. What then? What would be your next option? He has progressed, let's say, mildly, not a huge burden of disease. He's mildly symptomatic.
So this patient again, as you've put that the patient is mildly symptomatic, doesn't have a very large disease burden. We all know from the data that switching from one hormone to another hormone immediately really doesn't make a difference in terms of efficacy.
Perfect.
So even if this patient is just mildly progressing, has a rise in PSA, may not be too symptomatic, but has new lesions on his PSMA PET scan, and is now having a testosterone level less than 50 or less than 25 also, I would probably change this patient to docetaxel. Then I would put this patient on the second line hormone therapy after I finish 10 cycles of docetaxel as per the tolerance.
Okay, so docetaxel, again, just as a side thing, do you give only for 10? Do you continue beyond 10? Because remember, the data says that it is to be continued till progression. The 6 cycles was for HSPC.
The 6 cycles is for the HSPC, but if we look at the TAX 327 data, they have used it for 10 cycles. I generally use it for 10 because most of the patients can't go beyond that.
Okay, perfect. Next slide, please. Dr. Avinash, you can take this. Next slide. So, Dr. Avinash, patient has progressed after the PEACE regimen. Suman showed us that after the high volume disease, you would want to give PEACE to everybody, and being as updated as all of us are, I'm sure we are jumping to give PEACE. What happens when patient progresses after PEACE? Because this is a thing we are going to see now.
So I've been very fortunate. Like none of my
No, you are going to get it. You are not gotten because PEACE was published this year. But I'm sure there's a horde of medical oncologists ready to jump the gun and give both. In fact, I have prescribed it for a couple of patients already. So I am really curious what to do next after that. I am kind of lost in that.
So I really don't have an answer to that.
Advait?
So Vamshi, just like you, I have also jumped the gun and I have started this regimen for 2 patients. Luckily, they are still in the chemo part. And
they will come after 2, 3, 4 years.
But they will come after 2 years or 3 years. I think at that point of time, there would be studies which would be coming up looking at this patient. But as I said, I would look at a 1 year cutoff of docetaxel re-challenge in these patients, or I would even look at going on to cabazitaxel for these patients. Of course, there is no data for that, or
Very
maybe
good.
even radium if there is a bone isolated.
Okay, I'll come to radium later. Next slide. Next slide. So these are the basic drugs used, and I think I'm not going too much into detail, but I got the impression that Cabazi is something which people seem comfortable to use, especially after docetaxel. Either you give one NHA, then docetaxel, another NHA, and Cabazi. So Cabazi is something which people are comfortable using. Next slide. And same way, NHA rechallenge, I think Advait was very categorical. Rechallenging immediately does not help. Maybe as a kind of a sandwich, though, again, there's no data to support that, but that's where it could be possibly used. Next slide. AR7 testing, Dr. Shruti, any thoughts on it? Have you regretted not having AR7 testing, or you think it's really not that big a deal now? Dr. Shruti?
Sir, I am not aware of this, sir.
Okay, fine. So AR7 basically looking for whether this will work or not. So whether your Enza-Abira is better or your taxanes are better. Again, a lot of studies, but it's kind of falling down the side. Okay, next slide. So this is what the data that Advait was talking about, that once it progresses, the second line responses next NHA is not great. Next slide. So next slide. Now, now coming to the molecular testing and what we should be doing now. Dr. Avinash, do you do molecular testing for your patients of metastatic prostate cancer? If yes, when? And what do you test for? Next slide and next 2 slides.
So I do that in once they progress, and if I have a tissue, I do for this Braca testing. And
so you do tissue BRCA1 and BRCA2, is that correct?
Yes.
Okay, next slide. Next slide. Next slide. Dr. Avinash, you can take Dr. Advait, you can take this question. When do you test? What do you test? Do you test for the HRR as a whole, or only BRCA1 and BRCA2?
So currently, Vamshi, we are testing for patients who are castration-resistant CA prostate. When they progress, I prefer to do a biopsy again, preferably from the lymph node site. If the lymph node is not available, then I do go back to the initial prostate biopsy if it is within first 2 years from diagnosis, and I do send for the HRR panel, not just for the BRCA1, BRCA2.
Excellent. Dr. Shruti, what's your thought on this? Would you test the beta biopsy? Would you test an archival tissue? Would you test at baseline? Because you know that a lot of your patients are going to get into a SCRPC state later.
So like Dr. Advait said, that if there's a lymph nodal progression, that is the best thing to do. If not, then in a bone progression or a disease where biopsy tissue will not be very nicely obtainable, then I would want to go back to my archival tissue. Also, if the archival tissue is way too many years back, then I would again want to do a biopsy in any
Okay, I think there's a lot of disturbance at one of these panelists. We are hearing a lot of disturbance. Dr. Devesh, what is your practice? Do you test? What do you test and when do you test?
Sir, again, I am practice at when the disease have progressed and all options are exhausted.
Right.
And then again, I prefer HRR and if possible, fresh tissue, and if not possible, less than 2 years, then we can obtain from archival tissues.
Okay, next 2 slides. Right. What about MSI? What about TMB? Dr. Devesh, do you test for it?
No, sir.
No?
No.
Dr. Avinash, do you test for this? Yes, no?
No, I haven't done it.
Haven't tested. Dr. Shruti, MSI, TMB?
Yes, sir. So I do it sequentially. So I first do the HRR and then MSI and TNB, and I have used pembrolizumab in a TMB high patient, but it was not very successful. I do it at the diagnosis of CRPC so that I save time, because it's only a matter of 6 to 8 months when I would want to use another agent.
Yeah. Okay. Dr. Advait, do you also test for MSI and TMB? Remember, I have put it up there. TMB was tested in... Okay, Kashish, could you just mute that one speaker? There's a lot of disturbance on that one speaker. Yeah, thank you. So, Advait, what do? Do you test for MSI and TMB? Remember, keynote 158, only 6 patients of CRPC. And there was really nothing which said that CRPC patients with TMB high will respond.
So Vamshi, we are doing testing for MSI and HRR both together whenever that we have patients who are eligible to get this testing done. The TMB, we do it only as a part of broad molecular profiling after counseling patients. If we are sending a test like Foundation Medicine or a Garden, then only we do the TMB. Otherwise, I generally do not ask for a TMB. I would go for the MSI and HRR testing for patients.
Excellent. Next slide. Next slide. I think PDL1 is pretty much shown to be negative, so there's no point in doing it. I'm not going there. Right. Now, DNA repair genes, we know in around 20% of prostate that is shown to be positive. Advait, your experience with HRR positivity? BRCA1, BRCA2.
So I have a patient.
Number, how many percentage out of the patients tested have come positive? Simple answer.
So BRCA positive, BRCA2 positivity about less than 10%.
Okay.
Is what we have, and there are HRR patients who are about 3% in these. There have been 2 patients who were checked 2 positive and 1 who came in as RAD51C positive.
Okay, that's actually very interesting. I have personally found only 1 BRCA2 so far in around whatever handful of 15 people we have tested. So interesting, your percentage seems to be higher than what I have been seeing. Great.
No,
next
I
slide.
said 10%. 10% of my patients.
It's higher than mine. Mine is less than 5%. So next slide. Okay, this is the PROFOUND trial. Next slide. We have discussed this to depth about what the cohorts were, how they use 1 and 1. Next slide. Next slide. And next one again. Next slide. So only thing which I really want to ask, Dr. Shruti, what about this subgroup? We have talked about it a lot of time. You know, the only benefit is there in BRCA2 and in BRCA1. And remember, the Triton 2 study looked only at BRCA1 and BRCA2. So would you do the full testing or not? Kashish, can I take 2 minutes more? I think we had extra time.
Sure, so please go ahead.
Okay, good. Yeah, Dr. Shruti.
So I think in the study they did the HRR panel. That's why that is being advised as far as the test that is required to be done. Apart from that, I think RAD also had some benefit. So
RAD didn't have any patients in the olaparib in the placebo arm, so I'm not sure what good that will do. Anyway, next slide. So this is about the PARP inhibitor. So final word, Dr. Avinash. Next slide. Would you use PARP inhibitor? If yes, when? And what would you use, olaparib or rucaparib? Next 2 slides.
So whichever the patient is affording, I'm okay with that. So,
okay, you're taking the safe way out. So and what about this thing? Supposing it's only it's one of the other ones, ATM. Would you still use a olaparib? Remember, rucaparib is approved only for BRCA1 and BRCA2.
No, I would go only with.
Okay, I'll not put you further on the spot. Next slide. So this was about PARP inhibitors. Next slide. Just a couple of minutes more. Next slide, please, Kashish. Yeah, now interestingly, this is the NCCN guidelines I downloaded today morning, and to my surprise, when they talk of CRPC, just look at what they offer. There is no mention of docetaxel, abiraterone, enzalutamide, which we all have been conditioned to using and which all of the panelists say that more than 60% will still need. But NCCN has gone totally in a direction where all these other things are relegated to other supporting treatment. So very interesting, the kind of discussion or the thought process, what is happening, at least in the NCCN. We can agree with it or disagree, but it's still interesting to see what they're talking about. Next slide. So finally, thoughts on the Vision trial, lutetium PSMA. Dr. Advait, have you tried it? Do you think it's useful?
I think, Vamshi, it is very useful for us with the current era of using upfront therapies along with ADT. We have another option in a 3rd line and beyond. I personally have experience of use in about 3 patients. Downside of the therapy is that it does need multiple sessions of treatment. It is quite difficult for patients. The bone marrow suppression is also something which needs to be worried about, and many times after lutetium PSMA therapy, giving further chemotherapy becomes very, very challenging.
Okay, so what about this, Dr. Divesh? What's your thought on this Vision? Remember, Vision tested lutetium PSMA against already used NHS. So I mean, that's a big criticism of the trial, that they did not actually use it against the physician's choice. So you still comfortable using it, or would you use it only in a scenario where there are bone only mets, not visceral mets and things like that? Dr. Divesh?
Divesh, you're mute.
Still, sir, my experience is no in this lutetium PSMA therapy, but can consider only in bone mets patients, I think.
Okay, great. So dendritic cell therapy, it is though approved by DCGI. I think that whole controversy and debate I will leave to another day. Other chemotherapies, Dr. Shruti, just final question to you. Dr. Lalit did ask us, what about injection Horn1 or tablet Horn1? Thoughts on that? Do you still use it?
So I use endoxan dexa. Yeah.
Okay.
Nothing more
Endoxan,
than that.
capsaicin, dexa, carboplatin, narpaclitaxel, and all that thing. Full
No,
disclosure.
carboplatin I use only for those who have neuroendocrine difference.
Okay. Full disclosure, I use Hornman even now in a patient last dose, nothing left. I do use it, and I have to say it does work a little bit. Right. Next slide. So this is where we are going forward in metastatic CRPC. I think these are the areas where we are going to focus more and more. PARP inhibitors, immunotherapy, androgen receptor inhibitors. There are multiple dual type of inhibitors and other things there, and in radiopharmaceuticals. So thank you everyone. It was a great panel as usual, and I enjoyed preparing for it and reading for it as usual. Thank you very much.
Thank you,
Over to the
Vamshi. Thank you to all the moderators, to the moderator and all the panelists. I now request Dr. Sachin Jain to please introduce our expert. Sachin, sir.
Thank you, organizers, for inviting me in this ICON conference. So our next expert comment will be given by Dr. Rohit Rubello. He is consultant medical oncologist at presently at Ananta Institute of Medical Sciences, Udaipur, and he is my colleague, and he will give his expert comment, and he will also answer your questions if any queries there. Thank you.
Thank you, sir, for those kind words. So I think there are a few practice-changing updates that have come up recently. I think PEACE-1 has given us an OS benefit in the high metastatic burden patients, and that is something that is going to be, practice-changing. The new data from Stampede in high-risk non-metastatic patients where adding abiraterone has shown a 9% benefit in overall survival. So I think even in non-metastatic patients, we are going to slowly start probably putting the patient on, the triplet therapy with docetaxel as well as abiraterone. The one more thing that I feel PEACE is going to give us an answer, whether the data that Stampede showed where addition of radiotherapy in low metastatic burden to the primary disease showed an overall survival benefit. So PEACE is also trying to test this hypothesis of whether it is going to work. The one important thing that we probably need to remember is Stampede actually tested,
good evening, sir.
Tested these things, using conventional imaging. That is, they used a CT scan and a bone scan. But in today's world, where most of us have access to PSMA PET CT, the whole game of what is the definition of low and metastatic burden and high metastatic burden gets changed, because there is going to be a significant upstaging of the metastatic burden because of a more sensitive investigation that is being used. So these are the few things that I think I just wanted to put forward, that we have sudden practice-changing upgrades, the role of radiotherapy in metastatic disease to the primary. There is now triplet therapy in high risk as well as triplet therapy in metastatic disease has now shown overall survival benefits in the preliminary data stage for PEACE-1 and in the advanced stage for Stampede. So definitely, the whole management of prostate is changing. What to do in the next line is going to be probably the most difficult questions for us in future. So it was a very great panel discussion by Dr. Vamshi, and I think he covered everything. So there's nothing much more that I could add. Thank you.
Thank you so much, sir. We'll move to our last session for the day. It is on bone and soft tissue sarcoma. And it gives me great pleasure to introduce our speaker, Dr. Jyoti Bajpai, who's a professor, Department of Medical Oncology at TMH Mumbai. And she'll be talking on the topic, newer therapies in metastatic soft tissue sarcoma. Over to you, ma'am.
Thank you very much, organizers, for this opportunity to share this stage to discuss about the current advances in systemic therapy of soft tissue sarcomas. And I will focus especially on chemorefractory subtypes in the interest of time. So what does chemotherapy sensitivity or resistance means? So essentially, if tumor respond and there is a durability of response, also if it improves PFS or OS meaningfully, not just a p-value, or if there are improvement in symptoms as well as quality of life, I consider them as chemosensitive. However, if the drug toxicity does not really justify marginal benefit, what we are getting, we tell that this is intermediate or resistant subtype of sarcoma. So most of the sarcomas can be classified as intermediate-to-resistant cytotoxic chemotherapies. However, there are exceptions like classic childhood cancers, Ewing's, rhabdo, osteo, and also synovial and DSRCT, etc. Angio and myxoid liposarcoma also shows variable sensitivity. So what does chemotherapy sensitive or resistant mean? Again, I will say they are highly sensitive to intermediate sensitive and then minimally sensitive and highly resistant. We are seeing left-hand side, the highly sensitive childhood cancers, while the right-hand side, there's highly resistant clear cell sarcoma subtype. So evaluation of drug development in sarcoma, started taking everything into one basket, all histologies, all grades. However, as we are moving, we understand that this approach was not really right, and more than 150 histologies of soft tissue sarcoma. This is definitely not a one-size-fits-all model. So, doxorubicin remains a reliable backbone right from the beginning. When in 1973, before most of us were born, even this drug has shown an overall response rate of 24% to achieve an FDA level indication, and since then it has remained as a backbone. Doxo-IFO combination has shown better responses and PFS, but not really and significant overall survival benefits. So majority of the time in metastatic disease, we rely on single agents. However, if we really want to achieve a fast response and if the base of the disease is really high, then we use combinations. About gemcitabine docetaxel combination, it has a higher overall response rate, PFS, and overall survival than gemcitabine alone, and it is also established as one of the important, chemotherapy regimen in this kind of tumors. This is the Geddes trial, first-line gemcitabine dosi versus doxorubicin, and the previous data, which was indicative that especially in leiomyosarcoma subtypes, this kind of combination works good, but in Geddes trial, it has shown that there was not really a meaningful difference in either responses or survival, and also toxicity-wise, doxorubicin fared better. So after this, majority of the groups, they prefer to use doxorubicin as first line. Doxorubicin has much higher overall response rates than trabectedin, but no difference in PFS and translocation showing the same. And as we told that in the beginning of evolution, there was one basket with all. Later on, as the refinement is happening, we understand that we need to select appropriately, and there is, not all sarcomas which behave similarly. Even in one particular histology, there are several subtypes. So this study, trabectedin versus decarb in liposarcoma and leiomyosarcoma, so median PFS was 4.2 versus 1.5 months. And this was FDA approved in 2015 for both these indications. However, we must understand that in lipo and leiomyosarcoma, there is not really any much similarity, or rather any similarity. There are really two different diseases altogether, and this difference should be appreciated. Some drugs work in one subtype, while other drugs work in different subtypes. So in the similar line, the eribulin versus dacarbazine study in both these sarcomas were done, and it has shown that the benefit which was seen in overall survival benefit, irrespective of PFS. So PFS benefit was not there, while OS benefit was there. It was predominantly in liposarcoma, and hence FDA approved this in this particular subtype. So Robin Jones have shown that liposarcoma is also not one disease. There are 5 distinct diseases, and myxoid is really showing a good chemo response rates, while well-differentiated has shown no responses at all. So there is differences among one histologies as well. Precision histology really matters, and pleomorphic and myxoid are the tumors which largely benefit. So there is a subtype-specific activity in liposarcoma patients, which was seen in this open-label randomized study of eribulin versus dacarbazine in patients with advanced lipo and leiomyosarcoma. And doxorubicin-based therapy and dedifferentiated liposarcoma in first line shown less than 10% responses, while PFS was 1.5 to 4 months. So not really so much good activity. Second line eribulin or trabectedin also was not so great. And again, as we are getting wiser with researches, we understand that there are more and more refinements, and we need to very carefully look into histologies, the different molecular characteristics of a particular tumor to really understand which drug will work best. So this from chemotherapy to newer directions and newer molecules, newer therapies. So selinexor versus placebo in 285 patients with dedifferentiated LPS, as we have seen, this is one of the area which is really an unmet need. Not chemotherapy did not show much promise. So this is a XPO1 inhibitor approved for myeloma and DLBCL and has shown some good responses in this subset. However, still it was not that great that it should come into as a standard. So variant dedifferentiated liposarc, CDK4 and M2 are recurrent driver amplifications, and these could be favorable therapeutic targets based on the earlier clinical activity. Palbociclib versus abemaciclib studies are conducted in this particular subtype, and median PFS, which is 18 to 30 weeks, is significantly better than what we are seeing with trabectedin, eribulin, or doxorubicin, the conventional chemotherapeutics, and this space is looking promising. There are these driver alterations are really very common, and they can be utilized. So miladitomid as an MDM2 inhibitor, it shows median progression-free survival of 7.4 months in this particular subtype, and currently both these CDK4 and MDM2 inhibitors are evaluated in phase 3 pivotal study. What about the recent FDA approvals? So PCOMA, another rare kind of tumor, and again chemotherapy doesn't work good here. So TSC1 and TSC2 mutations are described in this particular tumor, and thus they constitutively activate mTOR, and hence there is a role of mTOR inhibitor. So nab-sirolimus was found to be working in this particular subtype, so an impressive response of around 40% and stabilization of 52%, and it has got approval in this particular subset. About targeting SMARC CB1 or INI1 in sarcomas. So there is an oncogenic upregulation of EZH2, which is an oncogen which is a part of the polycomb repressive complex, and this is showing tagimetostat, an oral EZH2 inhibitor in patients with SMARC-B1 or INI1 absent epithelioid sarcomas, and has shown a good activity in this particular subtypes. 15% responses, which were also durable and prolonged. So, sarcoma, gemdosi also work, and with a response of 50 to 30%. So this is also to note, because many people think there is just not any activity. However, the durability of response is one problem. Paxidartinib, which is a CSF1R inhibitor in tenosynovial giant cell tumor, another rare variety of tumor, and there is good response rates which was seen, and FDA approved this drug for this orphan drug indication, but with a black box warning to monitor liver functions, which is a prominent side effect. What about actionable kinase rearrangements, which were found in almost 3% of cases? Is the MSKCC data in almost 7,500 patients, and also there's one of the patient which has shown an anti-RK fusion, has shown a remarkable efficacy. And I am thankful to Dr. Gounder, who has shared this patient's details with me. So larotrectinib in anti-RK fusion positive solid tumors work really better, and in all across solid tumors where this fusion is positive, this drug is having an indication. about other receptor tyrosine kinase inhibitors. So pazopanib in second line has shown a median PFS benefit, however not in OS. Pazopanib is also shown an efficacy in solitary fibrous tumor, and again one area where not much molecule works, and impressive response rate of 58%, which was documented with a median PFS of 6 months. Regorafenib versus placebo in metastatic recurrent sarcoma, osteosarcoma has shown a 13.6% overall response rates. And there are many other pan-RTKs targeting multiple receptors, which is being studied. However, there's no clear biomarker to understand which tumors or which patients will really respond. And lanreotide and ifosfamide paclitaxel is being tested in Europe, and it has shown some good signal in refractory OS, and this looks promising. Sorafenib versus placebo in desmoid tumors. This is a study from Dr. Gounder et al. From Sloan Kettering, and it has shown an impressive data in this, this one of the disease where again not much therapy work. Crizotinib in match positive clear cell sarcoma.
Interrupt you. 3 minutes left.
So there's low further see that this data can be reproduced. This phase 2 study of metastatic sarcoma, so immunotherapy, nuclear block, again shown some promise in specific histologies. So there is 20% responses here, and metastatic sarcoma has shown not shown good responses all across. There is some specific histologies which has shown a good response. The 16% response rates with myxofibrosarcoma, uterine leiomyosarcoma, UPS, LMS, and angio. Axitinib plus pembro data in alveolus of sarcoma, again, few subtypes of sarcoma where immune checkpoint inhibitors with various permutation combination really showing some promise. This is an interesting study of tetravalent death receptor 5 agonist antibody in chondrosarc, and it has shown a good efficacy. Engineered T cell receptor NY-ESO and MAGE4, and this is showing that there is a efficacy in myxoid liposarcoma, and this is Sandra Stata. And MAGE4 PCR in sarcoma and MRCL also has shown a good response, and median duration response was not reached. So again, this is showing very impressive data. This study is showing that there is objective response rates among patients with locally advanced or metastatic sarcoma treated with TVAC in combination with pembro. We have seen some good responses with TVAC in melanoma, and now this space is widening with sarcoma indications. So also one must be very about the pathologic diagnostic errors, and if we try to diagnose these patients centrally, there is discrepancy rate which is more than 10%, which is quite some. So we must try and diagnose them as accurately as possible by all means. These are the NCCN identified systemic therapies in sarcomas as a single agent. This huge list starting from doxorubicin to newer agents like eribulin, trabectedin, pazopanib, etc. Then TKIs, Glevex, sunitinib, regorafenib, and many others, anti-RK gene fusion directed therapies like larotrectinib. There are combinations which work. We have to use judiciously them. So towards my conclusions. So we should not overestimate chemosensitivity in sarcomas, and similar time we should not underestimate the chemotherapy also. We need to be in real time and realistic. So each histologist behave differently. Histology matters a lot. And also one must see if a particular histology was included in a particular trial before deciding treatment option. Diagnosis must be as accurate as possible because histology matters. and there are different strategies, there are different therapies which works. Also, try to discuss in multidisciplinary tumor boards as much as possible, because every opinion matters. And these are, these tumors are really challenging, being rare. There are not high quality guidelines available, especially if they are even further rare and ultra rare varieties. So every opinion matters, because you will not get easily randomized trials, and this space is developing. And here I would like to acknowledge my teammates here in Tata Memorial Hospital, also ESMO team and Stone Catering team, all the sarcoma groups, which are relentlessly working in this rare tumors progress. And last but not the least, patient and families. Thank you very much.
Thank you so much, ma'am. With that, we come to an end of our session for the day. But we would like to remind our participants that please join us tomorrow for day 3 of the 46th ICON conference. We have sessions on genetics, hematology, colorectal cancer, non-colorectal cancer, and also on GU cancer. With that, we come to an end of day 2, and we hope to see you tomorrow.